Good morning, everyone, and welcome to those present in the Council Chamber to the meeting of the Health Scrutiny Committee for Lincolnshire for January 2026. My name is Councillor Richard Cleaver, and I'm the Chairman of this committee. On my right is my Vice Chairman, Councillor Chris Reeve, and on my left is Democratic Services Officer Jess Wasser-Yates, and also present in the Chamber is the Health Scrutiny Officer Simon Evans. For those of us in the Chamber, if we have a fire alarm, we need to leave the Council Chamber through the rear doors, move through reception and assemble in the car park at the front and await further instructions. In addition to welcoming all members of the committee to this meeting, I would also like to welcome Councillor Steve Clegg and Maria Hume, who are the Executive Councillor for Adult Care and Health and the Executive Support Councillor for Adult Care and Health. Other participants will be introduced when we reach their item or when they first speak. The meeting is being streamed live via the County Council's website, and all your comments will remain accessible online after the meeting. With this in mind, I would like to welcome members of the public and press who are watching. Can I please remind everyone to ensure their mobiles, laptops and iPads are now on silent. And just for information of the committee, I do propose we'll take a comfort break after item 6 on community connectors and mental health and wellbeing hubs. So without further ado, we'll move into the agenda. Item 1 is apologies for absence of replacement members. Jess, to report any apologies.
Thank you, Chairman. We've received apologies from Councillor Morgan, Councillor McGee and Councillor Courier. We've also received apologies from Councillor Higgs, who was replaced by Councillor Pessell today. Thank you.
Thank you. I believe Councillor Pessell, you're covering for Councillor Higgs. Yeah, thank you. Item 2 is declarations of members' interest. Do any members wish to declare an interest? Ms. Ball.
Thank you, Chairman. Just to register my ongoing interest regarding working for Lincolnshire District Medical Services, which is lodged with Healthwatch. Thank you.
Thank you. Anyone else? No, I need to declare that I am a Lincolnshire County Council appointed partner governor representative on the Council of Governors of North West Anglia NHS Foundation Trust. Obviously, as usual, if you become aware of any interest at any point during the meeting, you can declare it then. Moving on then to item 3 on the agenda, which is the minutes of the meeting of the 17th of December 2025. We need to confirm the minutes as a correct record. They are found on pages 3 to 11 of the agenda pack. Do I have a proposer, please? Oh, Councillor Cullen, seconder. Thank you, Councillor Reeve. All those in favour, please show. All those against? Abstentions? Thank you. That's noted, and they are approved. Thank you very much. Moving on to item 4, which is the Chairman's announcements. These were circulated with the agenda as pages 13 to 19, and unusually there are no additional announcements this month. Does anyone have a question or comment on the announcements, please? Okay, thank you. Sorry, Councillor Mackinson-Saunders.
Is there any update on Spilsby?
Sorry, I can't hear you. Could you put your microphone on, please?
Sorry. Is there any update on the Spilsby GP practice?
Not that I'm aware of, but we can seek one for you if you wish. Thank you. Thank you. Sorry.
Obviously, that's related to my conflict of interest, but I'm happy to give a private update on that after the meeting, if that would be helpful.
Thank you for that. So I take the announcements as noted. Thank you very much. Item 5 on the agenda is the NHS Humber Health Partnership. This was circulated as part of the agenda pack on pages 21 to 36. I understand this is the first time for many years that the committee is considering a general update on the services provided in the hospitals in Grimsby and Scunthorpe, which are part of the NHS Humber Health Partnership. I also understand that around 40,000 to 50,000 people see these two hospitals as their preferred local hospital. Presenters from the NHS Humber Health Side Partnership, who are online today, are Dr. Nick Cross, Medical Director for the South Bank, and Dr. Lindsay Cunningham, who is the Deputy Director of Strategy. I can't see, I think I'm about to see you on my screen here. Welcome, good morning. Would you like to talk through your presentation in about 10 or so minutes, please, and then we will move to questions. Thank you very much.
Certainly. Thank you, Chair. I will just share my screen so that we can put some of these slides up and hopefully members can see that okay. Fantastic. So you've already had introductions. My name is Lindsay Cunningham and I am our Group Director of Strategy and Partnerships. And my colleague Nick, as said, is our Medical Director covering our services on the South Bank. So that's predominantly Grimsby, Scunthorpe and also our hospital in Goole. We're just going to run through this really briefly because obviously you've had an opportunity to hopefully to read the paper, which just gives a bit of an overview of our group, our organisation. As you'll be aware, we've been through some changes in terms of forming the Humber Health Partnership Group. And I just want to give a little bit of context, and then Nick's going to talk about some of our sort of key challenges, areas of change, etc. So really just to set out, Northern Lincolnshire and Goole NHS Foundation Trust, Hull University Teaching Hospitals Trust are still independent sovereign organisations, but we formed a group a number of years ago now, established formally in August 23, and really the purpose of bringing these organisations together as a group was around about trying to solve some of the really difficult challenges that both individual organisations face, particularly around things like clinical recruitment. So some of our services where actually there's national and even international shortages around some of the real specialist services and specialist clinical roles. We've struggled to fill some of those vacancies for a number of years, but actually been able to offer joint posts where our clinicians can work across organisations, where they can undertake more research, where they can have different types of roles, has enabled us to start to manage some of those real areas of difficulty. And what that starts to do is help us to build more sustainable teams in the long run. This is a long process of work, there's a lot still to do, but really it's starting to give us some of those benefits that we can see by working as a bigger group and sort of sharing and learning across both banks of the Humber estuary. We have a single executive team. So people like Nick and myself work across the group, working with our operational teams. So our care groups again span both banks of the Humber, and what that does is it allows us to take areas of good practice in one place and share it with others. So that's really a little bit of the context of setting up the group. Apologies, bits on my slide. We also just, and again, none of this is new. You know your populations and your areas better than we do. That is, you know, your role as local councillors. But really, just when we start to think about the services that we provide across our region, so across the Humber local authorities, into North Yorkshire and into Lincolnshire, we need to think about some of the real challenges around the health inequalities that we see in our communities, things like access to cars and transport. So if we look at the rural geographies of East and West Lindsey, East Riding, there's big rural areas that we serve, but actually we also have quite a number of populations and communities who don't have access to reliable transport, and that means we need to think about how we provide some of those services differently and tackle things like some of the child poverty that we see in the area, that which has an impact on demand for our services. So we know that these things are related. So we really, when we're thinking about planning our services for the future, we're really cognizant of some of the underlying challenges in our populations. I think some of the details are in the paper, but we just wanted again to highlight in terms of where patients flow into our hospitals. Obviously, predominantly, we look to those 4 Humber local authorities, but actually there's quite a number of patients, particularly from East and West Lindsey, who look to hospitals that we run in Scunthorpe and in Grimsby. But also on the sort of north end of the patch, we do also have patients coming from North Yorkshire down into some of our services. So we have a broad area. We need to engage with lots of different local authorities as partners, and it's really important that we don't miss out people that are on the borders and on the sort of outside of that core 4 local authority areas. This slide just sort of does the same in reverse, so it looks at each of the Lincolnshire local authorities, and again you can see the vast majority of residents look to ULHT, but actually there's a sizable minority that also look to some of the neighbouring hospitals in Northern Lincolnshire and Goole, or NLAG, clearly one of those. And just for the benefit, this map also helpfully sort of sets out, so the blue line is broadly the catchment area for NLAG, but one of the things that we also see is that different services have different catchment areas. So when we've looked, for example, at our maternity services in Grimsby, we know that actually there's a pool further down the east coast. A number of women and service users come from Mablethorpe, from Louth. We even have some coming as far as from Skegness, up into, not many, but some into services in Grimsby. So we do need to understand all of those patient flows when we look at planning services for the future. So I think hopefully the map's helpful just by giving a bit of that context. I'm just going to hand over to Nick in a second. I think one of the things we also wanted to provide a bit more information on in terms of context of our update is really just around some of the changes that we are seeing to NHS services, both ours here in Humber Health Partnership, but across the country, really driven by a lot of the new policy that sits within the government's 10-year plan. So that came out last summer, so in July. And what we're doing, working with all of our partners, is starting to think about how do we respond to that shift of services from hospitals into community, supported by digital, supported by prevention. Really, none of these ideas are new, but actually some of the big challenges that we face as hospitals are because we get to problems too late. And actually, if we can work with our partners in primary care, with local authorities, with others, and try to get upstream of health problems, there's a lot that we can do so that actually the hospital just becomes the place for the really specialist end of care that can only be done in a hospital. Things like complex surgeries, the things that really need our hospital expertise, but actually we find better ways to support people with some of those other health conditions, so that they don't have to travel those long distances that we know a lot of people do to get to hospital services. So that kind of sets a bit of the context of some of the way that we're starting to think about changing our services. And I'm just going to hand over to Nick to run through the next few slides. So Nick, over to you.
Yeah, thank you very much. Good morning, everybody. My name is Dr. Nick Cross, Medical Director for the South part of Humber Health Partnership. And I just want to start by sort of reiterating the first major national strategic goal, which is to move activity from hospital to community. I think that us as a group, and myself personally as a GP by trade, absolutely recognise the need for a thriving community health service, including community services and general practice. And also that focus, the latter bullet point on that particular slide, emphasises that patient flow. And again, how do we as a place, and these are some of the challenges, how do we as a place try and prevent unnecessary admissions where clinically appropriate to do so? And when patients are admitted, how do we ensure that their length of stay is as short as possible and they can return back to their home or as close to home as possible? So if you could just move to the next slide, please, Lindsay. Thank you. So a national context, really, and I think we're all aware that across the NHS, we are challenged. We are challenged by an apparent mismatch of capacity versus demand. And hospitals are under pressure. We hear it on the news nearly every night about the high demand in our EDs, and actually locally high demand in our urgent treatment centres as well, which is up significantly, over 10%, for no obvious reason from when we look at our local population. We also recognise and have recognised for many years now the impact of the change in demographics and the increasing number of older people who bring with it more complexity, more long-term conditions, and increasing frailty, along with the loneliness agenda as well, which is something that we should also bear in mind with these patients. And again, we're noticing, because of the increase in complexity, that patients are staying longer in hospital because of the complexity. So, we have significant challenges in managing those patients that are medically fit for discharge but can't leave the hospital. And we've got some bullet points there that just illustrate some of those particular issues. Care packages that have not yet in place, limited resources in terms of community reablement and rehabilitation, beds or residential capacity, nursing home capacity, and then also some of the community housing complexities and arrangements. And just if I bring some local context, so what does that mean for Lincolnshire? We currently have in our DPOW, in our Grimsby Hospital, we have 30 patients from Lincolnshire that are currently medically fit for discharge, but are unable to, but are still residing within a hospital bed. We have 15 in Scunthorpe, and we have 1 patient in Goole. So it's a significant number of patients that are taking an acute medical bed, but actually don't need them, and there are better alternatives for those patients to get them home or as close to home as possible to continue their rehabilitation journey. We absolutely recognise, though, that this is not a problem that one organisation can solve in isolation. It is a system-wide, place-based problem, and we require close working between all providers, ourselves as hospitals, our community services providers, our social care, adult social care services, and our housing and charitable voluntary faith and social enterprise partners too. Next slide, please. So in terms of the flow, we have two main cohorts of patients that we manage. One are the emergency patients that come in through our front doors, and then we have our planned care patients, those coming in for a planned procedure or operation. Clearly, the two are linked and are very dependent on the flow through our hospitals, and hospital flow links to the waiting times in our EDs, which impact on ambulance handover delays. And actually, those ambulance handover delays also have an impact on the level of risk in our community of our patients that are waiting for ambulances. And clearly, that's not an ideal situation that anybody would want to be managing. But if we are also unable to discharge patients out of our hospitals, then that has the potential to mean that we have to cancel operations, elective operations, because there are no beds available for them. Again, something that that is a position none of us want to find ourselves in. So there are many benefits of how we of improving flow by, first of all, trying to prevent people coming to the hospital in the first instance and providing that really robust and comprehensive community network of services for our patients and families and carers. Also about improving the waiting times for people in ED, and also the patients waiting for their elective care, and which is why we have to come together as a system to look at how we start to solve some of those problems. And we are making some good improvement. We've started a weekly place-based meeting involving all stakeholder parties, including local authorities, ICB, community providers, and ourselves as the hospital, really looking at how we challenge ourselves to improve flow through the hospital for those patients who do not require an acute medical bed. And there have been some successes with that. In the main, actually improving relationships between ourselves as different providers, and trying to understand the problems and challenges that we are all experiencing. If you move to the next slide, please, Lindsay. At Humber Health Partnership, one thing that has changed very recently has been a recognition that clinical leadership needs to be at the forefront of all decisions that we make in terms of how we provide our services and how we how we work together as a system. And we've set up two main forums which facilitate those conversations, and you can see those on the slide there. But the focus is very much on clinical leaders determining clinical care and some of those solutions, and then working together at place to look at how we can effectively deliver those, so that the patients and those families get the care and that they rightly deserve, and that potentially haven't had over the years prior to the group structure forming. Next slide, please. And this is a slide really that I think just illustrates where we are coming from in terms of Humber Health Partnership as a group, and that is that, you know, the communities, we passionately believe that the communities deserve the best healthcare we can provide for them in terms of safety, in terms of responsiveness, in terms of access to specialist services. And we are absolutely determined through our organisational changes that we are making and changes to the service configuration that we can move along that journey, and hopefully together we can move along that journey and provide better services for our communities. It's something we all want. Thank you.
Thank you, Chair. Very happy to take any questions at that point.
Thank you. Thank you for the presentation. So we now move to questions. If you would like to indicate to me or to the Vice Chairman, if you wish to speak, please. I have the Vice Chairman as the first one to speak.
Thank you, Chairman. Thank you for the report. When you were talking about the number of patients that's currently experiencing delayed transfer of care at the various hospitals, I thought you maybe quoted the figures as separate for Lincolnshire as opposed to the North Lincolnshire. Is that correct, or was that a total number of people that was experiencing the delayed transfer of care?
So those were the total number of patients for Lincolnshire alone. That excludes North East Links and Northern Links. North Links, sorry.
Thank you. One more thing. The transfer of patient data from one hospital to another across the county boundaries, is that something that's a problem, or is the data, patient data, freely available?
Shall I pick this one up, Nick? So data is complex in the NHS, and there's a lot of work happening between partners to improve how we share data. So the short, simple answer is the data that's needed at point of care is there. One of the challenges we have as a hospital provider is that our systems are not automatically linked to GP systems in primary care, nor are they automatically linked to ambulance services and other providers. But over the years, a lot of work has already taken place to start to build the connections between those different sets of data. And one of the things that as a group we're doing is just in the process, I think as of about a week or two ago, having procured a new electronic patient record system. So that's our core system that holds all the data for any patient who uses any of our services. It's going to take us approximately 3 years to implement that new system, and that will work across the group, so across NLAG and Hull services. And what that will, the reason it takes so long to implement is because as we do it, each area that we look at, we're going to make sure that the data is flowing as it needs to within our services, but also that we're able to link to other services for patients when they need it. That's a really long and complicated answer, but I think it's just, it is really complex. If a patient is coming to our services, we will have the data that we need, to treat that patient safely. But actually, there's a lot of work in the background to do to get the additional benefits of data sharing that can be unlocked as we start to do that new piece of work.
Yeah, I'd just like to also come in. I think the challenge is a good one, and I think it is often an issue of finding the single source of the truth that we all sign up to has been a challenge for many, many years. We do utilise a particular software package that does provide that in terms of non-criteria to reside patients and the the resources that are required within the local authority, and we do share a single source of the truth in terms of that list.
Thank you.
Thank you. Have Councillor Smith next, please.
Thank you, Chairman. Councillor Reeve has sort of jumped me really in taking my question, but it was that residents in West Lindsey tend to use Scunthorpe Hospital quite a lot, and if they have to go or taken by ambulance to Lincoln Hospital, there doesn't seem to be any transfer of information from those two hospitals. So will Lincoln be included in this new development of transferring information? Thank you.
So yes and no. So they're not part of the EPR procurement because that's an internal system. But one of the things that, as I said, all our partners, so whether that's EMAS providing ambulance services, general practice, there is work both locally and nationally to ensure that we're joining up patient records and patient care. And actually the most exciting, I think, probably the right word, piece of development in that is actually around the NHS app. And so what is already possible, and a lot of people don't realise, is that if you have the NHS app, you have a lot of your healthcare records yourself. As a patient, you can take those records to any provider, and actually one of the shifts that certainly the national policy is seeking to do is to try and make sure that actually that NHS app as the front door to your NHS services, you hold your own record because you it's your health data, it's not anybody else's, as the patient, and actually because we can start to build things through the NHS app. That won't be right for everybody, and obviously there's a lot of work needs to go in place to make sure that patients don't have access to the smartphone, etc. But as we continue to integrate services more, we have to be able to share that data, and the NHS app and some of the investments that are nationally going into that, so things that we can't do locally but nationally, will really help to speed that up in terms of that integration.
I have Councillor Mackinson Saunders next, please.
Thank you, Mr. Chairman. Well, I hate to burst your bubble, but I come from Louth, and the stories we hear about Grimsby Hospital are awful, and I really, really mean that. Sharing of the information is poor. The stuff doesn't go back to GPs. Strokes get sent from. We do not have a choice. You go where the ambulance takes you, and therein lies the problem. Louth Urgent Treatment Centre usually says go up to Grimsby. You get to Grimsby A&E, and you're probably sitting there 12 hours plus, and you can't get back in rural areas on buses. People have to pay £30 to get back just to Louth, and that's going up all the time. Honestly, I could have a complete and utter litany of how we view failures at Grimsby in particular from Louth and District, let alone anywhere else in the East Lindsey area. But you do not speak to East Lindsey District Council at all. It's just like we're in a different world because we cannot find out the information we need about how our patients are treated. I can come here to Lincolnshire Health Scrutiny, but not everybody in our area actually goes to Lincoln. And we are kept in the dark. We don't know what your services, how they're evolving. I run a baby bank. I know plenty about maternity services. I know that the girls from Louth don't necessarily get help with breastfeeding like they should do because they're told, you're from somewhere different, you're from Louth, we're from Grimsby. People in A&E are rude to people as well and say, why have you come here? You should be seeing your GPs, or you should be in Lincolnshire. You know, it's just awful. And I don't know what you're going to do to try and solve that. But please speak to East Lindsey District Council. We have huge health inequalities along the coastal area, Louth, Mablethorpe, Sutton, keep going down the coast. We never speak to you about it, and we should do. Honestly, it's a really sad state of affairs.
So trying to work out whether Nick or I were going to come in first there. I think the first thing I'll say is very happy to talk to anybody that wants to speak to us. So we'd be more than happy to come and spend some time with, whether that's with yourself or some councillors from East Lindsey. We
Right, I'll
recognise
sort
that
that out. Thank you.
that we're not always getting things right. And I think Nick's talked about some of the challenges within our services, but there are many. Some of them are local, some of them are national in terms of the NHS and the pressures that we're under, but we know that we don't always get everything right. I think one of the things that we recognise particularly challenging for people who live on the boundaries between services is that different things are available in different places, and that's not necessarily the services we provide, but sometimes some of the, whether it's a voluntary sector organisation or a local council or a any of the other people who provide services in this space, quite often if you live on the wrong side of a particular street you can get something or you can't, and that causes problems, and really it's on all of us to work together to try and resolve some of that, but we're very happy to follow up some of those, some of the specific points if that's helpful.
That's brilliant, thank you.
Thank you. I have Councillor Pessel next, please.
Thank you, Chairman. I think that's on. In regard to your problems with capacity, what is your current bed occupancy rate trend, and how bad has that been likely increasing in recent years? So could you give us a rough guide as to what sort of bed capacity you would be looking at to mitigate the worst effects of seasonal increases, demographic increases, and would you be putting that through to government? And on top of that, what sort of measures are you taking to look at medium intervention capacity, in so much as I mean capacity for patients who are purely needing assistance due to frailty rather than particular illness, so do not require a medical bed but require supported assistance hopefully in the community. Are you communicating with central government to get greater resources for that? And if so, how productive has that been?
So I'll kick off with an answer and then I'll let my medical colleague correct me when I get it all wrong, because my doctor is not a medical kind. But I think in terms of the specifics, I can't give you exact numbers around beds, capacity bed occupancy, other than to say that it's consistently for the last number of years been higher than what the national guidance says. So we should have about 92% occupancy. We're consistently at and or above that in terms of our bed base. Just in terms of over the current winter, just as an average, we have across our two South Bank sites, so Grimsby and Scunthorpe, on any given day, we have approximately minus 60 beds in terms of our bed base, but we also have approximately 80 patients who are classed as no criteria to reside. So we have about 80 odd patients who are in our hospital beds, but actually need to be somewhere else. And we have about 60 patients in our EDs who need to be in our hospital beds. So we have broadly the right number of beds, but we don't have the right patients in them, and that's the sort of system challenge that we started to talk about. In terms of the frailty piece, all of the national models, all of the international evidence is that the best place for patients with complex frailty is not in a bed at all and not in a hospital. And you obviously asked about, have we been having those conversations with central government around funding? We're having those conversations as a system with our commissioners. So integrated care boards are the ones, and increasingly becoming those strategic commissioners. So they get the funding and choose what to spend it on. And actually, that's the place where those conversations have to happen. What our commissioners are going to be looking to do is to move an increasing proportion of resources away from organisations like ours and into the organisations that are providing that frailty care outside of hospital. In order to do that, we need to deal with the minus 60 beds problem. And that, again, because otherwise we can't move resources out of hospital because the hospital door is the one that's always open. So until we get those alternatives in place, the commissioners are never going to be able to move the funding and to put it into the places where you've rightly identified it needs to be.
If I may also come in on this. So, yeah, I mean, I think you summed up the situation quite nicely, actually, Lindsay. There's not a great deal else for me to add other than to say that in terms of management of frailty, it is very much about moving to community and away from the hospital, so aligned with that national strategy. We are looking at how do we develop frailty at the front door services to prevent admissions where that's possible to do so, and that involves all our stakeholders coming together to support those patients and their families. In terms of the bed capacity, you're right, Lindsay. We are often running at over 90% bed occupancy, which is in excess of what we're expected to run at. Often we'll get above that, and we'll have to therefore open temporary beds in order to manage the patients that are waiting for beds on our wards. But again, just to reiterate, we typically in Grimsby will have a full ward's worth of patients who do not need an acute medical bed and who are waiting to be discharged home or to an appropriate place in the community. Thank you.
Thank you. If I could just ask one supplementary. In terms of the impact that the bed pressures are having on elective procedures and other side issues, what is your current policy and how effective is it at mitigating the impact on elective procedures, and are you managing to reduce the additional weight being placed on those procedures, or is it still in an upward trend?
You want me to comment to that, Lindsay? Thanks. Yeah, so we have a set of protocols that we enact according to the level of clinical risk that we have in over our hospital and at place. So and we will nationally they're called OPAL levels, and OPAL 4 is our highest level that require us to take the sort of highest level of mitigation, both within our organisation, but also across place and with our ICB colleagues too. We are mindful, usually at those, when we reach an OPAL 4, we have significant weights in ED, we have significant weights with regards to ambulance handovers, and therefore the risk within the community of patients not being able to get an ambulance when they need one is significant, and the risk of harm therefore is significant. We therefore need to look at how we manage our beds, how can we facilitate discharges where that's appropriate to do so, and how can we work with our colleagues to look at reducing some of the non-criteria to reside patients, but also how can we open up temporary spaces which those we can look after our patients. In NLAG, in Scunthorpe and Deepow, our estate is configured in such a way that actually we can't have corridor care that you will see in our hospitals. However, that doesn't take away the difficulties that we have in finding patients' beds, and we'll often find that our EDs, our emergency departments, have patients lodged in there and taking up rooms that that patients who need ED need to go into to get assessed, which therefore leads to delays within our EDs. So it is a complex problem, but we do have a risk stratified approach to managing this within our organisation, also across the system. So far, sorry, just in terms of the impact on elective care, we have so far succeeded in managing the flow so that elective operations have not needed to be cancelled. If there have, there've been an absolute exception, and I could probably count them on one hand over the last few months.
Thank you.
Thank you. I have Councillor Lee next, please.
Thank you, Chair. Mine's actually a comment rather than a question. I'm a former nurse, as people know, 25 years, and I'm absolutely passionate about healthcare. And I was interested to see that page 23 of this report talks about the NHS 10-year plan. And one of the 3 pillars of that plan is preventative healthcare. And I think we all know the impact that type 2 diabetes has on the health of the community and the challenges that poses. And since 2019, Lincolnshire County Council have had something called the Integrated Lifestyle Services, and it has a number of focuses that include smoking cessation, falls prevention, but also weight management, physical activity, and a drink less programme, and all of those impact on type 2 diabetes. But yesterday, we got an agenda for a committee next week, and the Integrated Lifestyle Services is the money for public health is to be diverted to children's services, and it will mean that we no longer have the weight management, the physical activity and the drink less programmes. And I find that deeply disappointing, and I'm going to keep saying this publicly because it needs to be said in every committee that I'm at. It's deeply disappointing, it's short-sighted, and it's in direct contradiction. No, I'm sorry, this is scrutiny, and I will say my piece.
We are scrutinising
Yeah,
Humberside.
and I'm talking about the NHS 10-year plan.
Once. So could you please address yourself to the item under discussion? Thank you.
Yes, I will, yeah. As has been laid out in this report, councils do have a duty to work in partnership with healthcare providers, and public health should support community and hospital care. And I will say that, and I will say that everywhere I go, Councillor Cleaver, because I think this is hugely, hugely important.
I have Councillor Reeve next, please.
Thank you. I was quite dismayed to hear from Councillor Mackington-Saunders that there's still situations going on where people turn up at hospitals in Grimsby and Scunthorpe and they're told, you shouldn't be here, you should go to one of the hospitals in Lincolnshire. 7 or 8 years ago, I took an elderly friend of mine to Scunthorpe on the advice of the 111 call service, who said, please go to Scunthorpe Hospital and they will sort you out there. When she got there, she was told, what are you doing here? You should be in Lincoln. She felt that this was another example of the NHS saying, oh, you're a certain age now, we're not bothering with you. She was so upset that she refused to go back to Scunthorpe ever again. And I just wonder, are the staff being briefed that it is everybody from Lincolnshire's right to use these hospital facilities? And or is it just being kept in the management circles? And if not, the staff need to be briefed not to be telling people that when they turn up that they're not entitled to be there, because they are very much entitled to be there. Thank you.
Thank you. I would absolutely agree with your comments. Anybody turning up to ED, irrespective of where they reside, are entitled to be seen. They're entitled to be treated with respect and with dignity, and have exactly the same service, irrespective of the postcode.
If that could just be fed back to the staff as opposed to being kept in management circles, that would be great. Thank you.
Please be assured that will happen.
Thank you. I have Liz Ball next, please.
Thank you, Chairman, and thank you for your presentation. I am here to represent Healthwatch, and obviously we're well aware of all the local and national challenges that you've articulated today. But from a patient safety point of view, I just wanted some assurances around when patients are waiting for a long time that their safety and dignity are being maintained, and if you can give us some assurances regarding that, please. Thank you.
Do you want me to go, Lindsay?
Yeah.
Absolutely. This is, you know, we are facing situations with a with the demand that makes us all feel very uncomfortable, and we are absolutely mindful of the impact that that may have on individual patients and their families and carers, and therefore their dignity and their well-being whilst they're under our care is of utmost importance, and we will and endeavour to take their need as well as we possibly can do, irrespective of how long they're waiting. We have processes in place should they deteriorate that can be recognised, and therefore the care can be expedited should that be required. But it is something that we are very mindful on, and we challenge ourselves on that in many governance meetings.
Thank you. Councillor Martin next, please.
Hi, thank you, Chairman. Just going back to a point that was mentioned a minute ago about where are we? Patients be presenting themselves at the hospital after being they turn up, they're told that they shouldn't actually be there. They should use Lincolnshire services. I'm aware that ambulance teams have an iPad that tells them the best hospitals to go to. So there is data out there that directs people to relevant places. And if GPs, for example, because I know a lot of GPs will go, we need to go to XYZ hospital. If GPs under 111 service could use something similar to that, piggyback off that system, then I think that would help people. My main point, though, is I just wanted to talk about patient flow. It mentions in the report about the patient flow system, and you said you have weekly meetings to help improve this flow. Do you actually collect data at A&E to find out which patients are presenting themselves that should have gone to a GP service first? That's the kind of information that I find is useful to understand why so many people are at A&Es. And at the other end of the scale, when you discharge patients, do you use a system where you can discharge a patient into like a holding place in a care home, etc., to try and take the weight off the hospital service? Thank you.
Thank you. So if I could come to the first point in terms of we do collect that data, and actually it's a good question to ask and very opportune. And the reason I say that is that we currently have a piece of work that's ongoing this morning with our ICB colleagues and our place-based partners, looking at missed opportunities to divert people away from the ED to other services that may well have been able to manage their needs. So we do collect that data about the appropriateness of ED and whether or not other services may have been more appropriate. I think it's really important that, you know, often if somebody turns up to ED, it may be a reflection of the fact that we just haven't quite got our community services right and or accessible enough, or advertised them sufficiently, and that people feel as though there is no other option but ED, and actually that may be an incorrect assumption. So I think that as an organisation, as a place, we always need to keep challenging ourselves in terms of, are we delivering what the patients really need and want? In terms of the discharges, so again, I suppose we are holding those patients, but we're having to hold them on our wards at the moment. And as I mentioned before, probably a ward's worth of patients who we are holding in a hospital but who don't need to be there. And the reason why we're holding them on the ward is that following conversations with our partners and looking at the capacity and demand of specific community beds, whether they're reablement and rehabilitation beds, whether they are residential homes or care homes, that clearly we haven't been able to identify an appropriate bed for those patients, hence why they're still in hospital. In an ideal world, those patients, though, would not be taking up an acute bed, which would therefore free up beds for those people in A&E who are currently waiting for that level of acuity in their care provision. Sorry.
Thank you for that. And next question is from Councillor Mackinson-Saunders again, please.
Sorry, I think you'd be fed up with hearing from me. At the last, don't agree. At the last meeting, we talked of the health scrutiny. We talked about cancer care, and we looked at the figures for all providers in the area, and Grimsby was falling under where it should be, and we were told that you were in special measures. Can you tell me how you're actually solving that problem, and how can you reassure people living in the northern part of East Lindsey and probably in West Lindsey as well, that they are getting the service that they should be getting under the NHS?
Thank you. So cancer care is an utmost priority for us. We recognise that the service that we've been able to provide those patients isn't to the standard that what we would strive to provide, and that's also been recognised by NHS England, and hence, as you say, we are in a tiering meeting in order to help support us in the delivery of that. We are looking at, therefore, how do we configure our services in terms of to free up appropriate capacity for the demand, and be able to therefore meet our constitutional standards with regards to cancer. We recognise, though, that this is a journey. It's not something that we're going to be able to turn around overnight, and that's for a variety of reasons, whether it's relating to workforce issues, and recruitment has been a challenge for us, or whether it's accessible, can't get my words out, apologies, access to pathology testing, histology testing, and also access to radiotherapy. We know where our problems are. We have a plan to try to solve those problems, which we are working hand in hand with NHS England, and we have improvement trajectories that we can get to the stage where we can come off tiering and deliver our constitutional standards for our patients. But it is something that is going to take a period of time to get to, if we are being absolutely honest about it, and that's what we want to be.
Do we have a timeline then? How long is it going to be before you would get to where you should be?
So I think that varies according to the cancer site and the cancer organ that's affected, and I don't have those figures, unfortunately, Councillor, to hand.
We'd be happy to provide some further detail if it's helpful to members after the meeting. I think just to add to what Nick said, we recognise that so cancer is our top priority. So cancer and urgent emergency care, which I think we've talked a lot about the pressures in terms of our ED, are our two top priority areas for improvement. We are receiving support from NHS England, from our local Cancer Alliance and other organisations. So they've brought in additional people to support us to develop those plans. As Nick says, we've got a really good understanding now of where the challenges are, which we perhaps didn't have this time a couple of years ago. And really the part of the rationale around bringing the group together was about how we could get a better handle on things like cancer performance, because these are really specialist services. A lot of the very specialist care is provided out of Castle Hill, but what we need to do in terms of improving that cancer performance is every single step in the pathway. So everything from I go and see my GP, I've got a concern, there's a referral made, I need to get a scan, I need to get an x-ray, I need to have an outpatient appointment. Each of those little steps, there's an opportunity for a delay or for something to go wrong. So in terms of our improvement journey, we need to look at every single step and make an improvement in each of those areas. And that's what that support from our national colleagues is helping us to do. But in terms of some of the specific detail, when maybe don't have that to hand, but I'd be happy to provide a short update afterwards, if that's
really
helpful.
Useful. Thank you.
Thank you very much for that. Councillor Lee.
It's a genuine question. I wanted to ask if you feel that things are getting better within the NHS, because I've been waiting for an operation, and I've only been 6 months between consultant referral to operation date. So in Lincoln, it feels like it's getting better, and I wondered if that's the same across the whole piece. I think the numbers were the lowest this month, weren't they, for 2 years or something for waiting lists. Is that the case where you are? Do you feel that things are improving and getting better?
I think that's a really difficult question to answer. It's probably very subjective and will depend very much on what specific part of the NHS that you are touching with. In terms of the specific piece around elective or planned care and the impact of the pandemic, we are still living that, and it will take, from our organisation's perspective, several more years before we manage to completely remove that backlog. We're working on our plans at the moment in terms of how many months and years that will take. And again, that differs dependent on the specialty. One of our particular challenges is around that areas where we've got real clinical vacancies. So of course it's harder to clear a backlog if you've got 2 or 3 consultant vacancies, so we don't have the staff. We've been historically filling them with locums, but that's really expensive and we've got financial challenges, so we can't do that. So there's a lot of in that space. Yes, we are starting to make those improvements, but it feels like there's a long way to go. I think one of the things I would say is that there's where I would say I think we are making progress is around that integration piece. So we are, from I started my career in the NHS about 9 or 10 years ago, and organisations didn't talk to each other. We were actively encouraged not to, and to compete with one another and to fight for business. And that was one of the things that means that you get these opportunities for people to fall through the cracks and things to take longer. That does feel like there's a very different environment that we're operating in. It doesn't mean we've fixed everything, but community services, general practice, hospitals, we function more as one health and care system, or at least the aspiration is to do that. And that the way in which organisations work together has definitely shifted and changed for the better. I don't know, Nick might have a different view, but that's mine for what it's worth.
So my view is that if we can achieve the national strategic aims of hospital to community, analog to digital, and treatment to prevention, then things will absolutely feel better. And if we succeed in that, then we'll have succeeded by redesigning our local health service to meet the needs of our communities, to wrap around patients who perhaps are living by themselves, but with digital technology and smart housing, we can monitor those patients to allow them to become independent, but at the same time recognise early signs of deterioration and support those people early on, rather than reaching a crisis and needing to come to hospital. And I think that, along with our charitable, voluntary, faith, social enterprise sector, again supporting patients, working with our community services and general practice, upskilling our GPs to manage things that are traditionally managed in hospital. I think if we can get to that stage, and I think that's a lot of people's aspirations, but if we can get to that stage, then the impact on hospitals and freeing them up to be able to focus on the issues and acuity that they need to and that they're designed for, then I think that the services that our community will get will be better than they are today. It is a journey. We are coming together. It's about relationships. It's about how do we work together within all the financial challenges that we have, and you as a local as an authority, local authority, have financial challenges. So do we. So do general practice. We need to come together and redesign pathways with the patient at the centre of that pathway. And if we get to that stage, it will be better. We're not there yet, but I think we will get there at some stage.
Thank you for that. Finally, Councillor Kendrick, please.
Thank you, Chairman. My question might have been answered by the previous question because I had to go out the meeting briefly, but I'd be interested to know whether the services in your area, in case of people presenting with mental health issues at A&E, if you have the same sort of links that they do in Lincolnshire in terms of cooperation with the local mental health trust, whether you have a similar arrangement in your hospitals in the Humber area, because it's an area which is obviously of great concern for people presenting and needing the support. And if it's not there, it adds to the problem. Thank you, Chairman.
Thank you for the question. So I'll be honest, I'm not sure what ULHT's relationship is with RDASH, but I know that in terms of our relationship, we have a very good working relationship with RDASH for mental health patients, working with EMAS, RDASH and ourselves in order to ensure that wherever possible, patients with mental health issues as their primary reason for needing medical attention doesn't occur in ED, but can occur in a place outside of ED. And we've been successful in working together to ensure that that happens. Now, clearly, there are some times where mental health patients come in with a mental health crisis, but also have physical health problems, then obviously they'll need to come to us in order to have those managed in the first instance. But working very closely with RDASH's mental health team, their crisis team, etc., we have developed some new pathways to improve the care of those mental health patients, in particular managing their crises in an effective and dignified way.
Thank you. And finally, I have Councillor Welbury, please.
Thank you, Chair. I'm late to the table. No, I just wanted to pick up on something. It was an observation, really, about communication, that you said how important it was that you're now communicating together. I just wondered in these weekly meetings whether GPs are actually included, because my observation is this from, I represent Boston. GPs are a business. And they will do what is in their best business interests. I've had a couple of cases in my area whereby the GPs have actually refused or amended the prescriptions that have been given out by hospital trusts to patients on the basis of them being too expensive. And it's not an isolated case. And in one case, it has resulted in the patient actually being readmitted to hospital for not having the correct medication. So I'm very interested in this communication. Now, let's hope it's not just verbiage and that the actual root causes of the issues that we face are discussed and they are implemented, because, like I say, GPs are a business, and at the end of the day, it seems that they will do what is best in their best interests. Thank you, Chair.
Thank you. Does anyone want to come back on that? From
I obviously can't comment on the particular point of behaviours that you've mentioned, but what I would say is that the relationship between secondary and primary care is absolutely crucial. We're looking after the same patients, often the same conditions, and therefore we need to be absolutely aligned in what our management plan is between both organisations. We are working closely with our GP colleagues across all the 4 places that we provide care for in our communities, and we have set up specific groups looking at how we can come together to redesign pathways to ensure that the care that our patients receive is as effective as and efficient as it possibly can, and it's delivered in the most appropriate place. So where we can, how do we involve GPs in the delivery of care, working hand in hand with our consultant colleagues, or where can that care be delivered perhaps in local GP surgeries rather than coming to a outpatient department or needing to be admitted? So it is something that, again, it comes down to relationships, it comes down to communication and that joint vision of what we're aiming to achieve, and it will continue to progress. Diabetes, that was mentioned earlier on, has been something that we've discussed in terms of how do we at place manage the impact and demand that both type 1 and type 2 diabetes has on our communities and on all our healthcare providers.
Thank you for that. I have no other speakers waiting to ask questions. Thank you very much to our presenters for answering our questions. We now need to move to a proposal. My suggested proposal is that the presenters be thanked for their presentation on NHS Humber Health Partnership and for answering our questions. That the committee notes the outstanding issues highlighted during the session, and that the committee requests a further report from the Humber Health Partnership in 1 year's time. Do I have a proposer, please? Councillor Mackinson-Saunders, thank you. Councillor Welbury seconding, thank you very much. All those in favour, please show. Anyone against? That's unanimous. Thank you very much indeed. And thank you again to our presenters.
Thank you, Mr. Chairman. That was really useful.
Thank you.
Thank you.
Thank you for your time.
Bye-bye.
Thank you. We now move on to item 6 on our agenda. And I apologise to our speakers that you've been kept waiting slightly. This is on community connectors and mental health and wellbeing hubs. This item was circulated as part of the agenda pack on pages 37 to 99. Our presenters, who are here in person, for which thank you, are Victoria Slate, Head of Partnerships and Health Inequalities at Lincolnshire Partnership Foundation Trust, and Sarah Bryan, Head of Mental Health, Learning Disability and Autism Transformation, NHS Lincolnshire Integrated Care Board. Thank you for being here. Would you like to speak through your presentation in about 10 or so minutes for us, please? Thank you.
Thank you. I'm going to lead on this presentation and Sarah will be with me for the discussion afterwards. So this report is designed to give you an overview of the community connectors and mental health and wellbeing hubs that have been put into place over the last 6-7 years really. They were part of the community mental health transformation work for which Lincolnshire was an early implementer site in 2019, and they have evolved and grown over that period of time, rolling out across the entire county. This report is to explain the evaluation that was completed by the LORIC, which is the Lincolnshire Open Research and Innovation Centre, to guide us in the future aspirations of these of the connector role and the mental health hubs, and to help us understand some of the challenges that we may have faced with these hubs as we've moved along. So to give you some background around the hubs, there are currently 15 hubs across the county providing 135 satellite and outreach places for people to access. But as I said, they are county-wide and they have been put in place based in national policy, originally the NHS long-term plan, and now, as you heard previously, the Fit for Future 10-year health plan by the Department of Health and Social Care. They are predominantly voluntary community faith and social enterprise-led spaces, but the idea of the community mental health and wellbeing hubs was that we provided an integrated space for people to access high quality mental health and wellbeing care. They were designed to support people around things like meaningful occupations. So, for example, how do we get involved to support our mental health around perhaps accessing employment, or it could be a volunteering opportunity, or it could be just living well in our communities. They were also designed so that people could access support around housing, so how to maintain their finances, to address any housing issues that they may have. These are well-known triggers for people to escalate into mental health care. And what we wanted to do was also to enable the access to social prescribing opportunities. So to be able to address isolation, loneliness within our communities, and make sure that people who are also experiencing serious mental illness may be able to connect with others and receive the support that they require. So as I previously said, we are looking in the prevention space with this work. We want to make sure that people feel that they're supported to maximise their independence, make sure that they're improving their quality of life, and also increase the number of people who live longer in good health care. So this evaluation took into consideration all of those points. We hope that our mental health and wellbeing hubs offer a really welcoming non-clinical space. That being said, when we set out on this journey, we wanted to create a very homely environment for people, but also provide that specialist intervention where needed. We wanted to make sure that there were people on the ground that people could recognise and they could relate to. So the community connector role that's been put in place is exactly to do that. So it's there as a face for the community, but it also convenes multiple organisations at that locality-based level. So bringing together partnership boards where people are able to share what they're doing, understand the needs of the local community, utilise population health data, and really manage those gaps that we do see presenting. And being mindful, I guess, of the geography of Lincolnshire, it is very different, as you are all well aware, in different areas. So we wanted to make sure that that was in place. Additionally, and in the report, we've cited that there are 25 night-to-light cafes. There is one additional twilight cafe as well that looks after children and young people. But the nightlight cafes were put in place as a resource to help people in those hours, perhaps where people more historically struggle with their mental health, so sort of 4 o'clock through to 10 o'clock at night. And they are open at various points across the county, across 7 days a week. So what the evaluation there found was that for every £1 that we've invested into these hubs, we've had a social return on investment of £7.76. That's a really good return on investment. It did range across the hubs from £2.30 to £16.56. But what we know is that when we put the hubs and connectors in place, there was a phased approach. So there's some impact around that, but the average was £7.76. The report did highlight some key findings, that indeed we had achieved safe and welcoming and inclusive spaces, that people were able to access professionals and services, that people felt that they had that social connection and community engagement, and that there was a range of wellbeing activities both within the hubs and in those satellite provisions. People fed back to us that the community connectors had acted as trusted navigators and facilitators within their local systems, which is fantastic to hear. And what I will say about the evaluation, and hopefully you've had a chance to look at it, is we did a mixed methodology approach to this piece of research. So we interviewed people, we interviewed organisations, we looked at data, and we wanted to make sure that it was really reflective of each area. So it was done in each area and then brought together at a county-wide level. The community connectors have really supported involving people with lived experience and co-producing what's required. So we've got a really strong community asset development, which is very person-centred, providing that integrated approach across the entire continuum of care. Between September 23 and March 25, 107,000 attendances were recorded across the hub satellite and roving outreach sessions, and most participants were regular attendees, so we've got that continuity of care, which we know is really good for psychological containment. We know that the hubs have been described as local lifelines for individuals facing isolation, poverty and mental health challenges. And we know that community connectors have reduced some of the pressure on statutory services by being able to signpost people, deal with situations in their community more effectively, join together with other colleagues such as our mental health social prescribing link workers, our peer support workers, and create what we're describing as an effective community container, which makes sure that people are able to remain at home and not escalate into crisis, and as we know, isn't the best place for them to come into hospital. There are still challenges around this, so we still know that some of the rurality and transport links present us with a challenge, so we are looking at how we can address those, and that correlates with our need for these satellite and outreach spaces. We know that we also have a blended workforce model across the community hubs, and that's across both paid and volunteer workforces, and in some areas that volunteer workforce tends to be the same people volunteering, so we're looking how we can bring new volunteers in, open up new opportunities for younger people to volunteer as well, so that they get the experience they need potentially to move into employment moving forward. We know that there's a big ask on this workforce as well, so we're mindful of putting in supervision, wellbeing support, reflective practice, and working in that really cohesive way so that we get the very best out of people and we don't experience that burnout. We are currently in the process of procurement around the community connector and wellbeing hubs. So we're looking to increase that offer even more as we move forward. We've also published recently and launched our Better Lives Lincolnshire Alliance Voluntary Sector Faith and Social Enterprise strategy, which was attached. This was a strategy that oversees 5 pillars of work, addressing some of the challenges that I've highlighted, with the first pillar looking at empowering people and giving us real assurance around some of the other funding that we've put into place to complement the mental health and wellbeing hubs. Volunteering, so making sure that we're generating volunteers and working with them, investing, making the very best use of our resources, and making sure that investment isn't just financial, but it's also about investing into people, looking at the resilience and sustainability of what we've put into place and how that will continue in the future, and also addressing some of the infrastructure challenges around transport and also digital infrastructure that we're presented with in a rural county. I think that concludes my presentation. Thank you very much.
Thank you very much for that. So we now move to questions. I have Councillor Wimhurst first, please.
Thank you, Chair, and thank you for your report. It was not really so much of a question, but it's more with regards to the Integrated Lifestyle Service. Why aren't we just letting people deal with their own lives? Why are we getting in the way all the time? And I'm going to come back to what Councillor Lee said a moment ago. In the last point, about trying to restrict people smoking and drinking, and if I want to sit at home and eat a dozen pies, smoke a whole pack of cigarettes, that's up to me. And I think moving some of the funds to children's services is a much better option.
Councillor Cullen next, please. Thank you.
Apologies. Thank you very much, Mr. Chair. Thank you very, very much for the report. I just have a slight question, please. This has only come to my attention in the last couple of days, so I don't have all the details, but if I can just ask you. On page 6 of the VCFSE strategy, you mention that the MHDLDA vision to be realised and to contribute towards the following agreed outcomes includes maximising people's independence and improving their quality of life. One of my residents has been diagnosed with early onset dementia, and one of the challenges that she is experiencing at the moment is her bank has made the decision to remove her card, so she's not actually able to spend any money. She's only able to go into the bank, withdraw money, and spend the amount they let her have. My question is, obviously with her dealing with the dementia and her increased mental health issues concerning that, how is this helping improve her quality of life and monetary independence? Surely dealing with something like that and having the health issues and then having the stress of being restricted on the amount you are able to spend at any given time doesn't help people's independence. So if you could let me know. Thank you. Thank you very much.
I can probably come in here just more generally, really. Obviously, I can't comment on individual cases, but I think one of the reasons we set up the mental health and wellbeing hubs, and it was before my time that they came in, but when I saw what was trying to be achieved through a lot of this, I think it is really to try and address exactly what you're identifying. These are hubs which are not clinical spaces. They shouldn't be areas where people are concerned about going into. They are there led by local people for local people. There's a lot of peer support workers in there. There's volunteers who are members of the community. The connectors are the experts of those communities, so they start to understand what the issues are really in their local communities, and they invite in organisations like the Citizens Advice Bureau that would be able to help the particular individual, for example, that you're potentially talking about, and carers of those and all sorts of others. So it isn't just about what the hub itself can run. They work as a collaborative, really, with lots of other voluntary sector organisations. They invite partners in, and they become that sort of central hub, really, which is why it can help to people with all sorts of different issues which might be impacting their mental ill health, which is why really we thought, you know, it's a really important asset in the community for people to have there.
Apologies, Chair. Thank you very, very much. I'm not actually sure. I haven't had a chance to speak to her personally yet. This is from a third party. I'm not sure if she is aware of these hubs, but I will definitely, when I speak to her, I will definitely stress the importance and the help they can provide. So thank you very much. Thank you,
If I just come in on How Are You Lincolnshire website, it clearly lists out where they all are, how you contact them, and therefore for where the individual's based, you'll be able to see that and hopefully get the help that you need. But if not, we're happy to help direct you.
Thank you. Councillor Lee next, please.
Thanks, Chair. Thank you for a really good report. I like the theme that runs right through it around teamwork. It's not just about statutory agencies, it's voluntary and it's everybody working together. I think, for me, I'm always mindful that the sort of services you offer, they're for vulnerable people who can't help themselves. It's not about cigarettes and pies. It's about people with complex mental health issues and offering them support and help in a non-judgmental way. I think that's what the nightlight cafes and places like that do. My question, though, and I asked this on the previous item, do you feel that, and I know there's a long way to go, we've had austerity, we've had COVID, we've had all sorts of things, but do you feel that things are actually getting better? My casework feels as if I'm getting an increased number of people with autism who've got real problems, and I'm trying to help unravel some of that. And I'm not sure if it's getting better or not, but do you feel that things are heading in the right direction?
Thank you. I guess, as the previous item said, it's difficult. It's a really difficult question, isn't it? But what I would say is we've worked really hard here in Lincolnshire to integrate that team working model, and I think we've reaped the rewards, and this is exactly what this report shows. I think it's also one of the challenges is that as you begin to work more seamlessly together, you also begin to uncover other issues. And we're scratching the surface, really, of some of those other issues that we haven't been able to look at in more depth. So on the one hand, it's a useful exercise because we begin to understand more about what those community needs are, and we can begin to address them. In others, it can feel really frustrating for people, particularly as you've described with people with autism. So I think we are working together in a much more focused, integrated and collaborative way. We're also trying to drive that even further within the county and look at how we can do that even more across multiple sectors. So, yeah, that would be my opinion. I don't know, Sarah, if you want to add anything.
I was just going to say, I think Victoria and I and the colleagues that we work with are in a really privileged position because we actually get to hear directly from people and we get to talk to people and we get to see the case studies of where things are going really, really well. We also do get to hear where things aren't going as well, but we've seen such a change. I've been in my role 4 or 5 years or something like that, and this is scratching the surface of what we've managed to introduce over this period of time. I'm so proud of what we've managed to do. These, you know, it's not just the Connectors and Hub, there's the nightlight cafes, there's the mental health social prescribers, there's the way we've reorganised some of the mental health teams, the way that they work together. I think there's a much more open, I think we've raised the understanding of mental health out there, but as by doing that, you know, more and more opinions come to the fore, don't they? And of course, as Victoria said, more and more issues potentially you start to uncover. So we're part of that. I love my role in transformation because it gives me that opportunity to do something about it, because I think that's so important. So, you know, the more we can continue to do that, the better, really.
Thank you. That's really positive to hear. Thank you.
Thank you both. Have Councillor Smith next, please.
Thank you, Chairman. The work that's done in the hubs since 2019 has to be commended. I mean, it's an amazing service. But moving forward with the increasing pressures on funding and recruiting volunteering staff and setting up hubs in rural areas, it states in the report there's uncertainty over future funding, which is worrying as this is such an important service. Is there any insurance that the service will continue to grow after 2026? Thank you, Chair.
I suppose as the ICB Commissioner in the room, that's probably directed more to me. I mean, all I can say really is at the moment, obviously we're currently re-procuring this service and a couple of other services. We've not reduced the funding for that. I can't control what happens in the longer term future. That's why we have you people here to hopefully help advocate for us. But certainly, you know, it's... If you look at the 10-year plan, it's talking about prevention, isn't it? It's talking about investment into the community. It's talking about that left shift. The things that cost us more money are people going into the hospital setting. So the more we can do to help people in their communities and to help themselves, but just by giving them the tools to do that, to me, it's a bit of a no-brainer, but I obviously really advocate for it.
Councillor Kendry next, please. Thank you.
Thank you, Chairman. I don't know where to start. There's so many questions I'd like to ask. I think I might have to have a meeting with you outside. Somebody who ran volunteer services for LPFT for many years. And this is sort of like community support on steroids in comparison to what I was doing 8 years ago in terms of the hubs and all that's happening. But just a quick couple of questions. And as I say, I think I'll have to have discussion with you outside this meeting. In terms of the organisations that you contract with to provide the services, what standards do you require them to meet? I mean, think, for example, do you require them to meet the NCVO standards in volunteer recruitment and that sort of thing, DBS checks and so on? And also, what support do you give to the volunteers? What proportion of the volunteers are service users or former service users? When I was running the service, I had 40% were current or former service users. And how does this relate to the in-house volunteer services? The voluntary services manager I know at LPFT now doesn't even have an office. So I'm just wondering what's happened to that person's role. Has it been downgraded? Is it deemed unnecessary perhaps? Or does that person have a role in terms of monitoring the running of the various organisations with which you contract? And I noticed there's a 4.5 million figure quoted, but it's circa. I mean, are there any more precise figures on the breakdown on this? Because it's just a global figure. I think I'll stop there, Mr. Chairman, because there are many more questions I'd like to ask, but I think I'll have to have a chat with Victoria outside the meeting. Thank you.
Thank you. We'd like to come back briefly. Thank you.
Yeah, thank you. And yes, I'm very happy. I'm sure Sarah is to pick up with you outside of the meeting. What I will say is that this isn't purely about LPFT volunteer services. This is a collective volunteer piece of work that we do in collaboration actually with LCVS. And so we work alongside them, and the volunteering pillar within the VCFSE strategy is clearly being led by VCS services and in collaboration with us. In terms of LPFT volunteering, they have literally just arrived in my portfolio of work. So we are looking at them, and I can give you the percentage breakdown outside of here. But certainly we encourage people with lived experience. We're very clear about that. But we make sure that the safeguards are in place. We give them support, supervision. A lot of that comes in multiple ways, whether that's via LPFT staff or whether that's via other services out in the community. We're really, really clear that all the checks that are done are adherent to those standards, and we make sure that people are supported to go through those checks, actually. And we do the same with our MHD LDA co-production network, where people are volunteering in that space, which is administered via another VCFSE organisation for us. So everything is congruent with that, but I'm very happy to pick up with you outside of the meeting and we can go into more depth. Thank you.
Thanks very much. I understand there's some changes with the LCVS services, some combining of services going on at the moment. Yeah, but happy to have a meeting outside. Thank you, Mr. Chairman.
Thank you. Thank you. Councillor Pessell, please.
Thank you, Chairman. Like Councillor Kendrick, I could have a myriad of questions, but I'll restrain myself and try and amalgamate as best I can. In terms of the sort of return on investment being being £7.76. In that calculation, are you measuring the impact that it has on not just the direct client users of the services, but also their wider family and support network? Also, in measuring that, are you calculating the saving made in terms of diversions avoided from hospital or conditions which are highlighted that then need to be required in a more clinical setting, be it either from a mental health point of view or a physical health point of view? Secondly, are you finding that in terms of your clientele, different issues and different resources are having to be used when dealing with younger attendees as opposed to those of a more gifted age? Because we've seen the differences in the mental health impacts on younger people through social media and those other sorts of sources. And on the issue of IT, are you able to are you looking to establish a system where you can reach out to people beyond the locations through online resources and talking to them about their social media and IT use and how they relate to you and relate to others? Thank you.
Thank you. I'll try and answer your questions succinctly. So in terms of the social value calculation, there are there's a multiple number of proxies that are used to get to that calculation. It does look at divergence away from hospitals, and it also does take into account families and the impact on the same, and that's done via those interviews that I referenced, etc. So it is very much a qualitative piece of research that we then use the social value engine that we've developed, that was developed and utilised through the University of Lincoln. So I would say yes, but we within the report we could give you a breakdown of the proxies that we use to get to that calculation. You mentioned about the younger attendances and the resources needing to be slightly different for younger people. I mentioned that we have a Twilight Cafe specifically in place for younger people to access. That's delivered in collaboration with our CAMS, our Child and Adolescent Mental Health Service. There's only one of those at the moment in the county, but we would be seeking to improve that, I suppose, and offer that more widely. What I will say about the mental health and wellbeing hubs, they are an all-age offer. And we do see all ages accessing those mental health and wellbeing hubs, right from, I've seen babies in the hubs, all the way up to 90-year-olds who are volunteering within the hubs in some areas of our county. We do always take into account what that community need is, and so that's one of the roles of the community connector and the convening of the partnership boards, to understand what that offer needs to look like in response to what they're seeing within the hubs, and also the discussions across the wider partners. So we do flex that provision to try and respond to what that is. I think Sarah's going to pick up the digital question.
Yeah, well, I was also going to pick up the bit that you mentioned about beyond the locations, because although we talk about hubs, in fact, within the model, there's what we've termed satellites and roving outreach, which makes sense to us, and hopefully it does to other people. So what we mean by that is we're well aware that each area is really different, and you do need stuff based in a town centre, for example, but actually our communities are so rural and have such different needs that actually the reason the whole model is based on having some provision in other satellite settings. So, for example, in Trent, you've got something in the town centre in Gainsborough, but then Saxelby is also part of that area, but also needs a level of provision, but different provision because it's a different community to Trent. But then we have outreach on top of that. So the connectors and the hubs staff will go out to other villages roundabout, utilise existing assets within their existing voluntary sector settings, for example, and will therefore offer what's needed in those. And I have seen some of the offer, because we're well aware that parts of Lincolnshire have what people term things like digital poverty, or, you know, a lack of training and understanding. And we work with a lot of those volunteer organisations out there that are also able to offer support for people. So they will come into some of these settings to be able to make sure that people can offer that level of support. But we're certainly working really closely with our children and young people mental health team to make sure that what the offer is more aligned to what a community needs, and not specifically adults or specifically children and young people, because none of them are one thing, and children become adults, and all of those transitions that are needed. So we do work really closely together.
Thank you. If I could just ask one supplemental, and this is just of a personal interest. Do you work in conjunction with probation capacity to help reintegrate or divert people who have had contact with the judicial system, so that there's an impact on their likelihood of recidivism?
Yes, we do work in collaboration with the probation services. We have something in place in Lincolnshire called the Mental Health Prevention Concordat, which brings together multiple partners, one of those being probation. We also have a service within LPFT that looks at how we work with people who have had that judicial contact, and we're also working in partnership with Lincolnshire Action Trust around women who have had contact with judicial services, and to prevent women escalating into those services as well.
Thank you.
Thank you. I have Councillor Martin next, please.
Thank you, Chairman. Hi there. We have a well-branded hub in Grantham, where I'm from. It's very well known. It's you know, exceptionally well known in the community. They use a lot of social media and that sort of thing. Lots and lots of community connection. It's very good. I was going to ask you about standards and support. You know, how to ensure that, you know, the right vetting's done of volunteers and such like. So obviously you've got lots of vulnerable people go to these hubs, but I think you've kind of covered that. One question I do have though is that I think there might be a slight danger here that you may be centralising a lot of services in individual sort of charities, if you like, groups and organisations, where a community could have several different, you know, organisations that do similar things. How do you stop yourselves from creating like a vacuum, if you like, where you're concentrating everything on one hub, and you're essentially withdrawing support and funding from other community charities? I'm just wondering, is there some kind of way that you bring all these people together? Otherwise, you're going to end up creating one big, powerful group, and all the other charities are going to end up falling aside. Thank you.
So there's two parts to my answer, really. One is the creation of the VCFSE strategy is absolutely designed to ensure that we don't create what you've just described in a vacuum. We don't want to do that. We're really, really keen that we work with both small grassroots organisations all the way through to larger organisations, and we have representation within that piece of work from all of those partners. So I'm confident that we're working across the board there. I guess the other bit for me, we've already mentioned the local partnership boards, and we do encourage that there's an opportunity there with our connectors to work collaboratively, play to individual organisations' strengths, to respond to people in the right way across their community. This is not about centralising services. This is about creating a rich and diverse tapestry that provides that biopsychosocial model or holistic approach for the individual. And we also make sure that we monitor where the funding's going. We do our own quality visits. We take that all into account as we procure and go through that process.
I don't know if I can also just come in really briefly, just to say that it is really important, isn't it, that we make sure we keep that grassroots level that we have across Lincolnshire, because actually we're quite different to a lot of other areas that might have just one or two really big voluntary sector organisations. I think what we like, what we particularly value about ours is that it is really diverse, and a lot of the organisations that are out there specifically help certain cohorts of individuals, and we don't want to lose that vibrancy, and that's why that strategy has really been put in place to make sure that that's still recognised throughout that. That's why we do the outreach elements, not just from a geographical point of view, but to make sure that the need of those communities, and going back to what the connectors are about, it is about them. They actually lead the discussions. We're not the experts in what the communities need, they are. So that helps to keep that vibrancy alive. And whenever we make decisions about funding community assets, because we do sometimes fund through our, what's it called, the Mental Health and Wellbeing Community Investment Fund, yeah, sorry. Some of those, with the actual panels, it's not us deciding that, it is people who are out there in the community, people with lived experience and actual organisations that are helping us to make those decisions. So that's what I think helps us to keep all of that really important element in Lincolnshire.
Thank you. Councillor Reeve.
Thank you, and thank you for your report, and I commend the work that you do. A quick question around the homeless. Homeless people on the streets is perhaps the most public-facing aspect of people who struggle with mental health. Most people don't see what goes on behind closed doors, but people on the street who are homeless. And I just wonder, is there a pathway for those people to be contacted? Are you in contact? Do you go out looking for those people, or do you wait for those people to come to you? And given an ideal set of circumstances, hypothetical ideal set of circumstances, what would you change in everything that you do? Because I know it's not always about money or resources, it's just sometimes various circumstances that's stacked against an ideal situation. Thank you.
I'll come in around one element of this. I'm not sure if Victoria might want to come in around housing as well generally, but two of the elements actually that we fund as part of this, one is called Holistic Health for the Homeless. So we actually have a service that's more of a clinical element. It actually employs clinical staff that support that, and they do go out into the community to make sure that individuals who are homeless know where to go and have the relevant level of mental, physical health support that they need. They will also help direct them into relevant services if they need specialist support. So that's been running for quite a long time. It is only Lincoln based, so we are well aware that that's something we do need to explore across the wider county. And to support that, because obviously you can't just have a service and then expect homeless people to know where that is. We also support an advocacy service that is well known, that's based in the south part of the High Street, called part of Development Plus. It's called Project Compass. So that's also something that forms part of the portfolio of work that we have in place, that also makes sure it's there to advocate for people who are homeless, and to support them not just from a health specific point of view, but if they do need advocacy around anything else in their life that supports them to make them able to function in the way that they would like to be able to do, and to help meet some of their needs.
I'll just add to that as well that over about 14 months ago we put into place quite a novel role really around housing, and that was put in place between ourselves and the local authority to make sure that we were addressing housing needs, not just for people who might be experiencing discharge delays for leaving hospital, but also to address the triggers around when people become homeless, for example, because they don't have the right advice in place financially or around their tenancies. So what we're trying to do now is we're just in the process of drafting out a mental health and housing strategy which does pick up the homeless issue. We want a whole pathway of care around that to make sure that we are supporting people at that point of contact. The second part of your question was what would we change, wasn't it? And I think that's really important. Obviously, there are probably multiple things that I would change, but two things that struck me are I would really like us to be able to continue to collaborate in the way that we have done across those multiple agencies. I think the Mental Health, Dementia, Learning Disability and Autism Alliance is absolute testament to that. It's brought partnership working to the fore, and it enables a vessel for communication and decision making. That's challenging within the current times, and we want to be able to make sure that we can continue that integration and collaboration and make the best use of resources. The other part that we flagged very heavily within the VCFSE strategy is around the transport and infrastructure. I think that can cause us huge problems as a rural county, both whether that's digital access or transport to places. Now, some of that is aided through really good communication, and How Are You Lincolnshire as a website helps us with that. But this is still a challenge for those people that live where they're not on a bus route, they can't afford transport, they can't, they're in digital poverty, etc. We do try and address that with our outreach projects, but I think that is a challenge, and if we could do something about that, that would be brilliant.
Thank you very much.
Thank you. I have one more speaker, Councillor Mackinson-Saunders, please.
I feel a bit ashamed to ask this question because I don't think your publicity is very good. I actually had to write to the community connector in Louth and ask her where the hub was. And I'm pretty switched on normally. We had a discussion yesterday at my district council, East Lindsey, about I distribute the household fund, and we were having a discussion about where people could go for some debt counselling. And of course they say the CAB, but a lot of the people I deal with, there's no way they go to the CAB. And the portfolio holder at East Lindsey said, oh, I think community connectors might have that as part of their role. They didn't know. I do know about the nightlight cafes because I know the chap who runs that, and that seems to work extremely well. But really, I don't think anybody much knows about it in my area. I can't ever remember seeing a sign outside Trinity saying this is the community hub or anything like that. And I do feel ashamed to actually have to ask these questions. But it is a good idea what you do, and it is helpful for the community. But you're quite a well-kept secret in this bit of Lincolnshire, I'm afraid.
Shall I come in there? And that's so disappointing.
Please, I know the lady who's now doing the job, and I feel even more guilty asking you the questions.
No, don't feel guilty, because actually we need to hear that, don't we? I mean, we we have a comms person, we have somebody who, I mean, it's How Are You Lincolnshire? I'm going to keep pushing that because it's our resource. It's also elements of that are on connector support, obviously through the council as well. But, you know, all of the provision that's on there is all through that one resource, because we were well aware that people needed to know and be able to find what's out there. It's always the problem, isn't it, is trying to get messages out there, putting posters up, people don't read them, you can go onto the radio, depends who listens to it. We probably need to get better with social media, that we do actually use a lot of Google Analytics and things to try and see what the numbers of people going through, and it's been building over time. There's obviously more to do though, clearly, and we will feed that back to different settings. And no, it's useful to hear. Thank you.
Thank you for that. Councillor, you want to come in quickly?
It's two very quick ones. First of all, I think there's an opportunity there, Chair, for you to feed back to Chris O'Rourke that we could have something about this in the county news. Then people would know about it. But the second thing, really quickly, I only found out about 2 days ago, and I've been a councillor for 5 years on this authority, that there's a service called Liaise where people can get advocacy help, people with mental health problems. And I'm a nurse, I should have known that existed, but I didn't know about that either. And it makes you wonder about some of these well-hidden things.
I think I'm not sure I know about that either. So, but what I will say is there's lots of new things coming online all the time. And I know we are talking a lot about How Are You Lincolnshire, but there's a reason for that. It is a dynamic website, so our connectors actually feed into that, and we have a lead now in place who will do that. So I will go back, I will ask that question, and that would be really helpful, and we will continue to communicate as much as we can, because it's really important that people know about these things.
Thank you for that. I have no more questions. I would say it's very interesting to hear what was said about people's knowledge of the different hubs that are around. I will agree with Councillor Martin about the Grantham one is very well known, and certainly the one in Stamford is. So it's interesting to see that it's not the same across the county, and certainly in terms of social media and making and building its reputation and it becoming widespread the way in Stamford is exemplary. So obviously there's a lot to learn in terms of spreading that across the county. So thank you very much for your presentation. I'm sorry we're running slightly late. We now need to move to a proposal, members of the committee. My proposal is that the presenters be thanked for presenting information on the community connectors and mental health and wellbeing hubs, for answering the committee's questions, for offering follow-up with members outside the meeting as well, that the committee notes the issues raised during the session, and that the committee record its support of the work of the community connectors and mental health and wellbeing hubs. Do I have a proposer, please? Oh, crikey. Councillor Wimhurst, then Councillor Cullen as a seconder. Thank you. Sorry, you took me by surprise there. So many people put their hands up at once. And all those in favour, please. Thank you. Anybody against? No. So that was carried completely unanimously. Thank you very much indeed. Thank you for your help. And I will just add at the end, sorry, I meant to say earlier, it was an absolute joy to see a report that indicates so much working across community and joined up working within the community for this committee, having been on it for 5 years now. It's rare that we see something that where that shines out so well. And also it's a joy for the same reasons to see an independent scrutiny report from outside the NHS coming to this committee. That doesn't happen very often, and I'd be very grateful if we saw it a lot more often. So thank you again for that. We will now take a break. Apologies to our next speakers. We do need to take a 10-minute break, as I announced at the beginning of the meeting, and we'll come back in 10 minutes' time at 12 o'clock. Thank you. Okay, everyone, it's 12 o'clock, so we need to restart with item 7 on the agenda, which is non-emergency patient transport. Apologies to Tim and Joy for keeping you waiting. Sorry about that. Thank you for being here. So this is item 7 on our agenda, which was circulated as part of the agenda pack on pages 103 to 112. The presenters are Tim Fowler, Assistant Director of Contracting and Performance, NHS Lincolnshire Integrated Care Board, and Joy Weldin, Head of Non-Emergency Patient Transport, East Midlands Ambulance Service NHS Trust. Would you like to present your report, please? And then we will move to questions afterwards. Thank you very much.
Thank you, Chair. I'll present the report today, if that's okay, and then Joy will support in both things I miss, hopefully I won't miss many, and answering some of the questions. I'll take the report as read, if that's okay. The report sets out the background to the contract that we have from the ICB with EMAS for patient transport. We've got some comments in the report about the operation of the service in terms of service delivery principles, the local incentive scheme, complaints and quality, and I was asked to put in some comments about the eligibility criteria, so that's in as well. I think it's fair to say that the patient transport service is one that perhaps doesn't have the priority and focus that a number of other services do. However, it's very much a vital service because if it falls over, particularly in terms of discharge processes and bringing patients out of hospital, discharging patients after they've been in for outpatients and diagnostics, it has a massive impact in terms of how the whole system works. And I'll probably come on and bring that theme out as we go through. But for me, I've been involved in this in Lincolnshire since 2017. I think it would be fair to say that it's seen as a bit of an orphan service, and therefore we struggle to get the engagement and the support that we sometimes need for it. In terms of background, we have now a single contract for all journeys for patient transport that we undertake in Lincolnshire. Prior to EMAS coming in, there were basically 3 main contracts that we had. We still do some journeys outside of the EMAS contract where EMAS are unable, for example, where there's a significant distance. We don't want to take resource out of the county, so we'll call in other organisations to do that. And sometimes when the hospitals are seeing particular pressures, we will bring in supplemental support. But generally, the principle of the contract is we wanted EMAS to pick up all of the journeys for patient transport within Lincolnshire, and generally that happens either by EMAS staff doing these journeys directly or by subcontracting to taxi firms, and we may come on to that a bit more. The contract started in July 23. We were expecting to start it in July 22 following a re-procurement exercise. I think people will know that we had a procurement challenge which didn't really come as a surprise. Patient transport is very challengeable, and even more so with the new regime for procurements. So we expect that to happen in the future whenever we go out. It's a 9-year and 9-month contract. We took the view when we were putting the contract in place that we wanted a long-term partnership with our patient transport partner. The reason for doing that is that we've had previous contracts that have been 2 or 5 years. It doesn't give the patient transport provider time to get engaged with what's going on in the county. So we wanted that long-term contract. There is a notice period in the contract of 12 months, so it doesn't mean that we can't get out of the contract if we wish to do so at some point in time. But that partnership with EMAS is really important to us in the ICB. And there are examples now of the patient transport service and the 999 service working together, which is one of the major benefits that we saw of having EMAS in holding this contract. I've put in the report that when we were looking at this contract, we decided not to put hard KPIs in it. We do have service delivery principles that I'll come on to. We have a local incentive scheme. The idea of that is to try and work out what's really important. And if you look at some of the standards we've got in the contract, although the service delivery principles are not achieving what we would want them to achieve, if you look at the number of journeys and the number of complaints and patient satisfaction, we're generally getting few complaints about the service, and we're getting good patient satisfaction on the service, and that's really important. So I wanted to focus on what the important things about running a contract rather than hard KPIs. And I think we've had that discussion here, and sometimes quite an interesting discussion here in the past about why we haven't hardwired KPIs into the contract. So that takes me on to service delivery principles. So the service delivery principles in the contract are listed in Appendix A, and I've put a narrative in the report about where we are in performance, and you'll see that the performance has deteriorated with a number of those, and particularly since March we've had 3 that have improved and 6 that have not improved. March was the last time we came to the committee. I think the key issue for us is around discharges. Very important, we support the hospital system in making sure discharges work and work properly. We've been trying to work with the hospital to get those discharges and get them to have their processes to support discharges in a different way. And I think we're now at the point where EMAS have done pretty much all that EMAS can do. And we're now getting into a point where we need to do that deep dive with the hospital, and we've started a process with the hospital trust to look at that, look at what they can do differently. I tend to be a bit of a realist. That is going to be very difficult to do because the focus of the staff on the wards is not always patient transport, but what we want to do is try and put some targets into the contract from 1st of April with the hospital trust, so that we get more notice to EMAS of patients who then require patient transport on discharge. I think we have about 90% of our discharges that are done with very, very short time. It's about 68% that are done on the day, and 90% of those are done with less than 4 hours notice. So it's a real tricky set of circumstances that we're trying to manage. We want to pull that forward, and if we can pull that forward and get that focus on discharge planning done a lot better, it will mean that EMAS have more resource. It means that they are not cancelling as many journeys, and it would mean that they're not aborting as many journeys. So it's a lot of work to do, and I'll be realistic about the timing of that, but that will now start to have those conversations in terms of targets with the acute trust. I would expect it to start to improve from April, May, June next year. This year, so 26. That deep dive, we're happy to share, come back to the committee and share the information on that deep dive. I hope that will be helpful, so we'll see where that gets to. In terms of the local incentive scheme, at the bottom of page 105 in the report, I've started to set out where we are with the local incentive scheme. There are 3 elements to it. There are rebeds, which we are trying to avoid. There is a issue on patient and healthcare practitioner satisfaction, and then there's an element on social value. You will see in the report that I've outlined in very high-level summary where we are against each of those requirements. We've been through in terms of patient satisfaction, where EMAS are expected to produce an annual report to the ICB. We've been through that for 24/5, which is the kind of second period of the contract, and within that, we've signed off that report that EMAS have done what they said they would do. They've listened to what patients have said, and they've tried to respond to it, which I think is really important. Social value, this is about supply chain, it's about making sure we've got green policies in, and again, EMAS are doing that really well. In terms of rebeds, you've got the rebeds shown in the KPI SDP report in Appendix A. Again, it's symptomatic, the number of rebeds is symptomatic of the problems that we've got in getting discharges out of the hospital. So process there is that patients would be identified as being fit for discharge, patient transport being identified. Sometimes at short notice, it's impossible for EMAS to turn up and do those discharges, and therefore the patient gets rebedded. There is a penalty, financial penalty in the contract for rebeds, where they're at the issue arises with EMAS, and we are transacting that financial penalty to EMAS. That's a bit of a double-edged sword, because the more resource we take out of the contract, obviously less resource EMAS have to fulfil the contract. So it's an interesting conundrum that we've got, and Joy will probably comment on that at some point. So in terms of patient satisfaction, as I said earlier, we've got good patient satisfaction despite the service delivery principles not being met as we would want them to. And in terms of complaints, we have very, very, very few complaints on the service. The themes on the complaints, not surprisingly, are around the timeliness of transport turning up for discharges or not turning up at all. And I'm sure Joy would be able to talk a little bit more on that. So the themes of the complaints, I guess there are no surprises on. I think if we compare where we are with complaints with the EMAS service to the previous provider, we have a very, 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 very good news service story to tell. The previous provider used to have significant numbers of complaints, and EMAS have reduced that down radically, which I think is good. In terms of eligibility, you've got the national standards. We've put a table in the report that shows the number of people who had a eligibility assessment and what the outcome of that eligibility assessment is. Eligibility is nationally set for us. EMAS have a process that they go through when a patient contacts them or when a healthcare practitioner contacts them to work out whether eligibility applies or whether it doesn't. There is downward pressure nationally on eligibility, and obviously we want to make sure that we are fair and reasonable in applying eligibility criteria, and EMAS have a very defined process for looking at appeals for eligibility, which we review, and it works very well. So I think that's just a very, very quick run through. If people are happy, I'm happy to take questions.
Thank you very much. Councillor Reeve, you've put yourself first.
Thank you. Forgive me if this is a wrong category, but a few years ago, they used to have a system for appointments at hospitals where volunteer drivers would use their own vehicles. Is that something that's no longer used? Thank you.
Yeah, we still use volunteers. They do exactly that. It's around, our volunteers undertake about 7% of our activity on the whole. And we're continuing to recruit to our volunteer teams as well. They do an absolutely exceptional service. They're brilliant. Our patients really value that type of service as well. They travel miles. I mean, in an average month, they can undertake nearly 3,500 miles in doing that. So yeah, they're very much a part of our team as a whole, and we don't even separate them out. They're absolutely part of the PTS team.
Thank you.
Thank you. Councillor Smith next, please.
Thank you, Chairman. I have two questions, if that's all right. They're quite short. Has the new discharge centre at Lincoln Hospital improved the speed in collection and delivery of patients using the service? And also, the second question, EMAS seem to be using the service more for stretcher transport. And this requires, obviously, 2 members of staff, which uses up the resources. So is that an area that requires more funding? Thank you.
Yeah, we're still doing lots of work in terms of discharges and how the processes work. So we haven't seen a significant change in terms of how that's our journeys are booked with us and how like a reduction in any waste or any inappropriate bookings or anything like that. But actually what we are doing, we do have a dedicated discharge coordinator that sits with our team, and they are really working well with the discharge teams at the hospital to be able to really work through looking at those journeys in as much advance as possible, looking at how we schedule those journeys so that we're able to to ensure that we're maximising our capacity, but also, which would link on to your next question, which Tim will answer, is around ensuring that all those patients that are booked for specific mobilities are accurate as well, and that we're getting the best out of what resource we have available.
If I can answer the issue around stretchers, which are two-person crews, and it takes resource, a lot of resource that is not then available for other individuals. We are again trying to work with all of the hospital providers to make sure that when they book transport, they book at the right level of requirement for the patient. We have significant evidence now that a number of bookings seem to be on the basis that if you book a stretcher, it will be prioritised. That's completely opposite to what the way it works, because if you book everybody as a stretcher, EMAS need to turn up with a stretcher crew and it takes resource out. So we're trying to work with the trust around that. There is some national data that looks at the profiling across all patient transport services. It's only the NHS ones that we've got data on. Some of that data is a little bit out of date, but the latest data that we've seen suggests our profile for stretchers in Lincolnshire is above where it is nationally, and certainly is above where we are with Nottingham and Derby. So one of the advantages of the kind of the getting together of Lincolnshire with Nottingham and Derby is we can now share lots of detailed information. So stretchers is something that will be part of the deep dive and really needs to be. In terms of your question about funding, does it require more funding? I think that's a discussion that we will have with EMAS as we go into next year's contract round. It's complicated in terms of funding, because if we look at the way the contract was let, overall activity is within the parameters of the contract, but this resource issue in terms of stretchers where they're having to use two-person crews means that the profile is different. So we'll have a sensible conversation with EMAS. I'm not going to go into more detail than that in this committee, if that's okay.
Thank you for that.
I think generally we do have sensible conversations with EMAS.
That's good to hear. Councillor Martin, please.
Thank you, Chair. Hi there. Yes, my father actually is immobile. He uses this service quite regularly, and we've had several occasions where, for some reason, we've had to cancel the appointment because the transport can't pick him up and such like. It's all fine, and it's quite interesting because although looking at this chart here, there's a lot of red in there, and it doesn't look great. The general impression I get from people who use this, and including my own family, is that it's great. They're actually happy with it, despite the issues. And I think it's because they understand that you're kind of having to deal with organised chaos. You're really having to, your parameters are shifting by the minute all the time, and it's fully understandable. I've sat in hospital waiting for you guys to turn up, and it can be very quick and efficient or drag on quite a long time. But everyone's happy to accept that. It's just the way it is. So I wouldn't feel too bad about the sea of red that we've got in front of us. It's not that bad. One point I would have, though, is that when people try and phone the hotline, if you like, I don't believe there's a facility on there to say you're waiting in a queue and you're going to be a certain amount of time to get through. And I know we've had to do this, but other people I've spoken to as well have kind of given up trying to feed back information to you, like we can't go today, or the patient's ill and therefore can't be transported. I think that would be one thing I would look at, is just to get that phone line as efficient as possible so that people can get in and tell you what's happening, just to make your service run a little bit more smoothly. But apart from that, as I say, although it's a sea of red, I think it's pretty good.
Thank you, and thank you for that. And from the sea of red, we also share and work with the commissioning team and our contracting in terms of anything outside of the actual appointment time would hit the red marker, and so there's a lot of the majority of our patients are getting there perhaps 5 or 10 minutes after their time, so they're not all hours and hours late. So just wanted to kind of put that understanding there as well. There's a set parameter, and then there's patients that just sit outside of that. But you're absolutely spot on in terms of one of our biggest challenges is our call centre, and that working how best to be able to you know, cancel journeys that aren't needed, that don't just require a telephone, you know, you could use a system or something that could do that. Also conscious that there's a lot of our patients that don't use technology as well, and so there's trying to find the right balance within that. We've also looking at, we have two separate ways for communicating, so we're trying to ensure we've got this very clear split of availability for our patients to call directly, and then for our healthcare professionals to call us, because sometimes if a healthcare professional's booking for multiple patients or wanting an enquiry, it can take a long time, and so then that would negatively impact potentially on patients trying to make those bookings. So literally last week had a conversation with our IM&T team around telephony and what can we do better, how can we make it work so people aren't waiting so long, because that is one of the challenges. You're absolutely right. Sometimes people do understand that it is sometimes organised chaos because of how we're working with people, aren't we? We're trying to support people, and that changes our routine minute by minute. But I think we can be better specifically at that contact point and how we can improve on communications. I think you're absolutely spot on with that.
Councillor Mackinson-Saunders, please.
Thank you. We've heard about your how you work with Lincoln Hospital. How do you work with the trust up at Grimsby, please?
So we have exactly the same conversations that we do with our local hospitals as we do just on the borders there as well. So and we have discussions and regular meetings with the team up there, and that works really well. They are fully part of our escalation process as well, so they're very clear on who to talk to and when, and how we can help and support them. We also have those same conversations in terms of booking processes and how best we can do that. And in the areas where we sometimes see that challenge, and as Tim mentioned earlier as well, we have that interconnectivity with our A&E services and our colleagues there, and that's where we look to maximise transport provision as a whole, and what is the best option for patients at that time. So we link in with all our hospitals in exactly the same way and have the same contact.
So the problems are similar everywhere,
They are
aren't
similar,
they?
yeah, absolutely, and we'll try to work through them in the same way as well.
Thank you.
May I come back on that as well? As a commissioner, we work really closely with our counterparts in Cambridge and Peterborough, and in Humber and North Yorkshire. I have regular contact with them. We have a stakeholder group to which they are invited on patient transport. I think that we are getting to a point now where we've got good processes in place with Peterborough hospitals. We probably need to do a bit more work around Northern Lincolnshire and Goole. We've got some complexities around Northern Lincolnshire, where Northern Lincolnshire and Goole are partnering with Hull hospitals, and that makes a number of the journeys more complicated and longer distance. I think we'll see more of that as we go through the next 3, 4, 5 years, particularly around Peterborough, who are starting to use Cambridge-based hospitals more. And that means that we've got an issue for our patient transport, but also for our 999 crews. So it's a really complex set of dynamics we've got around it, but we've got good liaison and good relationships. The one we need to do quite a lot more work on is Queen Elizabeth at King's Lynn. So that will be one that we are aware of and are picking up. But again, they look to Norwich now a bit more. So again, taking a crew from Spalding and sending them to Norwich, that's a 3-4 hour round trip. But they need to wait when they get there. So there's a dilemma that the crews have in terms of if you're sending somebody to Norwich Hospital for one patient, what do you then do with that time if you've got to pick that patient back up in 4 hours? You can't really get back to Spalding and do another journey. So it's just knitting it all together. I've seen the way that journeys are planned. I can't get my head around it. I don't know, Joy, you can, but it's complicated.
Thank you. Councillor Pessel, please.
Thank you, Chairman. In regard to those longer journeys and crews being detained, etc., do you keep track of the hours, presumably hours, that crews are essentially taken out of service delivery, so that you can liaise back with the hospitals to try and find out how these can be improved? Secondly, in terms of your deep dive, will you be looking at the performance of pharmacology in how they provide discharge services? Because I know from personal experience that many patients can be held for a considerable amount of time beyond their predicted departure date because of delays coming from pharmacies. And finally, in terms of your appraisal as to performance, when you have a very good review from actual patients, but do you take into account reviews from the wider family, medical professionals, and also, say, care home providers as well, and how they interact with the service? Thank you.
So for the journeys that are long distance and out of area, so we do report on that, and we do monitor the time that's spent undertaking that. I suppose the ultimate responsibility is the patient is our responsibility, and also what we're trying to do, particularly with hospital transfers as well, is again it's that work that we're doing on the deep dive in the suitability. You know, is patient transport 100% needed, and also, you know, the patient does need to go for some of these the specialists, some of the hospitals as well. So sometimes the out of area hospitals where the patients are travelling to are for specialist treatments. So it's difficult to find that balance, isn't it, of can they go somewhere else that would be better? But we do undertake some of those conversations as well. So where we see patients travelling to certain clinics for certain treatments, we do have those multidisciplinary conversations. Is there an alternative for this patient one, so they don't have to travel so far, because that's also not great, is it, at times? And also it helps then keep transport within the county, and we're able then to keep more on schedule for things. So we do monitor those distances, and we do, where possible, try to find an alternative solution if there is one that's available for that. And in terms of that feedback from relatives, healthcare professionals, care homes, absolutely, that forms part of that LIS and that stakeholder feedback. So all those stakeholders are involved in that. And what we do as well is, and it just kind of links back to the point in terms of the, you know, cancelled appointments, or if we have to do anything different, we liaise a lot with patient relatives as well, and we get lots of feedback from stakeholders in terms of we have formalised meetings and we gain feedback that way. We also have routine ways of contacting. I think there's some in the paper actually in terms of we'll go to different departments at different points in time as well, and we've got a schedule in terms of trying to see, well, we have X amount of patients coming to your clinic. How is it working? Is there anything we can do differently? And that also helps when we're seeing higher levels of cancellations. Is it a particular journey in a clinic in a particular hospital, a particular area, and it enables us to be able to focus and work with stakeholders to find the best solution in terms of reducing it happening, and so lots of conversations happen over time with multiple people.
Should I pick up the issue in terms of pharmacology, medications being available so patients can be safely discharged? We do have a number of cancellations and or aborted journeys due to medications not being available and therefore the patient not being able to be discharged at the time that is booked for transport. And yes, we are going to pick that up through the deep dive. It's the deep dive will have the label of patient transport and improving patient transport. I think there will be a number of other benefits for other services that perhaps don't have a priority in focus to get that discharge planning correct and right. So community equipment, for example, again, not a service that has a significant amount of focus, but an absolutely important, vital service. And if you don't discharge plan correctly, you can get patients delayed in hospital because equipment isn't available. So I think although we're going to focus this on patient transport, the holistic approach to discharge planning will have benefits elsewhere.
Thank you.
Councillor Cullen, next, please.
Thank you very much, Mr. Chair. Thank you very much for the report. It's extremely detailed. Thank you. Thank you. I really appreciate reading it. Couple of questions. I used to work as a driver for the Boston Dialysis Centre back when it was based at the Boston West Hospital. It's moved since. And I also used to take my son to and from his chemotherapy treatment when he was highly immunocompromised, and I was available, so I didn't see the need to call on your services. My question is around the eligibility of drivers. I'm first aid trained, so what checks and regulations do you have around the, checking that a driver is suitable for taking a patient to and from treatment, please? Thank you.
If you're available and like to join the team, if you go onto the website, there is information on there. And so they go through rigorous vetting and, the DBS checks, all the kind of checks that we would have for ourselves, because they have that patient, direct patient contact. We asked, there's a specific criteria for the car that they have as well, so there's a specific criteria for the vehicle and the maintenance, upkeep, etc. around that. There's our individuals then will go through a training program as well, and that needs to ensure that those individuals can support in a first aid situation and circumstance, and that they're able to undertake CPR, etc. And so they'll go through that process as well, and then get given a set amount of kit and uniform, as well as markings for cars to be able to identify themselves as working with us from an identification perspective as well, because again that's really important, isn't it, in terms of being visible. So they go through lots of rigorous processes and assurance and annual checks in terms of driving as well, and all those things about driving licenses and things.
That's really reassuring to know. Thank you very, very much. Thank you, Mr. Chair.
Thank you. Have Liz Ball next, please.
Thank you, Chairman, and thank you for your presentation. And I think you've touched on some of this, but as Health Watch, I'll focus on patient experience, and you've talked about the wider stakeholder experience, and the council in front of me has talked about is own family's experience. But in terms of the individual patient experience, obviously you've articulated in the report that the number of complaints has reduced, which is excellent. But what else are you doing to collect that patient experience in terms of their feedback, given that they're prepared to wait, but are they getting a good experience despite that? Thank you.
Yeah, absolutely. And we have a team of people that we send out, so we do text messages. So we use an SMS service after each journey to be able to ask for feedback. And as I touched on as well, so not everybody has access to that or likes to do that as well. And so as much as it seems probably a little old-fashioned in terms of how we do it, we actually do send out paper surveys as well with a free post envelope. And we actually get a really good response from that. So we're so, we get challenged in terms of the cost of that, but actually we get real high value from that. And so, I've even answered the phone to an individual who was worried, am I too late to send it back, and talking to her, and I was like, no, we absolutely need that feedback. So we use the paper surveys as well to all patients who've travelled with us, and like I said, that's probably actually the best response we get is from that. So there's the text messaging surveys as well, and looking at going into next year in terms of having a dedicated team member to do a more face-to-face approach. How can we get some feedback in a different way as well? And you're absolutely right, there's people, and we don't rest on our laurels. People will accept a certain level of dissatisfaction or a slightly lower poor experience if they understand that there's a delay or a challenge, etc. But what we don't want that to do is to be the same person multiple times, etc. And so we also do a piece of work on that as well. So we monitor, if somebody's had more than one poor experience, and look at how we can make that better for that patient if they're going to continually travel with us as well. Because you're absolutely, sometimes once or twice people accept that that's fine, but it's really impactful if somebody travels routinely, particularly renal dialysis patients where they're 6 journeys a week at minimum, and so we do that work proactively, as well as we don't just sit and wait for a complaint or a concern to come in as well. So we're mindful of that, and we report all that into our contracting team from a quality perspective as well as from a performance perspective.
If I may come back on that, as an ICB, we are really keen to make sure that we have an understanding of what EMAS is doing and what the results of what EMAS is doing is in terms of patient satisfaction, but also in terms of healthcare practitioner satisfaction with the service. Excuse me, my voice is going. We have regular meetings with EMAS. We have ad hoc meetings with EMAS. EMAS have meetings which we join with various groups of providers. So with the renal service, which is managed by Leicester Hospitals, we have lots of discussion with them. Because I've been involved in this for a long time, some of the providers might know my name and will ring me up and tell me what's going on, and I will always respond to that. It kind of works well. So we've got various strands of getting that feedback and responding to it. I will always pass on representation that I have to EMAS, and generally EMAS respond really positively to that. So there are some providers who we work with who don't respond in the same way. It is so different, in my opinion, to the previous provider, where we would raise issues and I wouldn't get back the feeling that they were wanting to take on the issues and make a difference. I think that's different with EMAS. I would say that because Joy's sitting next to me. No, that's...
Thank you for that. Councillor Lee, please.
Thanks, Chair. It's a really interesting report. Thank you ever so much. As well as being a councillor for a long time, I was an NHS nurse, so this is like I'm really familiar with it all. And it's quite. I saw the bit about the cancelled journeys, and it's interesting because we often have things that at committee about facilitating timely discharges here and an adult, and everyone's got an opinion on it. And you just think, try being on the ground, and you might actually find it's different, because you only need something like a new medication or a test introduced on a very late running ward round to absolutely throw everything. So I do understand why journeys get cancelled. And my first question was, is it still the individual nurses who are and should cancel the ambulance? And I did used to. Or is it the discharge coordinator? My second point, many patients really do expect transport home, and I mean expect, because Lincoln was the heart centre, and because we had patients coming from Spalding, etc., they all thought because it was a long way they were going to get a free lift home. And I understand why, if they're old and they need, but not people who can sort out their own arrangements. So that really was an issue. I never once had an ambulance not turn up. It might have been about 6 hours late, but it always turned up in the end. Complaints, I was really impressed at page 106. You've had something like 46 complaints. There were 40 PALs and the rest were complaints out of 36,000 journeys. So I'd have to try and work that percentage out, but I'd say it was very, very low. And so you must be doing something right. My final question was, given the limitations of the vehicles you've got, the staff you've got, do you feel that within the service things are getting better? Because they were really bad about sort of 5 years ago or whenever. They were really bad. And I just wondered if you think things are getting better, journeys are getting to be more timely, you know, and things are being managed better.
Okay, lots of questions. From a cancellation perspective in terms of discharge, then the expectation is that the individual who made the booking in relation to that patient would cancel. We have introduced the ability for that to be done online by the clinician as well, or the you know, whoever was on the ward that was doing that booking. So the expectation is that the relevant ward or whoever's managing that individual's case would cancel. So yeah, absolutely. Sometimes that happens, sometimes it doesn't. And so when it doesn't, it results in an aborted journey, which has that impact in terms of you've got to travel to the ward, find out, then go back again, and then you might have to go to another hospital to go and pick somebody else because there's nobody else ready at that one. And so, as you know, it can cause challenges. So that's the work that we're doing. So, but the discharge coordinator is trying to proactively, that she's got a little team of people to ring wards in advance to say, example, is Mrs. Smith ready? Is she going? Has she got her medications? You know, just checking on mobility, all those types of things, everything ready at home. And so that we can start to ensure that people are focused on that. And if the journey is no longer required, then that's that opportunity there just to cancel and make a rebooking when needed. So there's lots and lots of work every day happening around that. In relation to eligibility, absolutely right. We get varying groups of people, and so we have some people who would absolutely only ever use us as a last resort, and sometimes not even then want to use us when they should be. And there's also you know, people that because it's available expect that they meet the eligibility criteria, and so that isn't the case. They shouldn't expect that journey, and so Tim mentioned it earlier in terms of how we do that. So we take the booking. If the patient is deemed not eligible, there's an opportunity to be able to appeal that decision. We have a clinician within our team. They then follow that up, review that patient, and you know, sometimes even if it's from where patient lives, there's no access to anything else, they have no other family, etc. And if they're going for multiple treatments, then you know, it may be on that case-by-case basis that's approved and reasonable. But also what she does is, we have aborted journeys where patients have made their own way home, so they haven't even waited for us sometimes, and so we go for them, they've gone somebody else and use an alternative. And proactively, our clinical lead will ring them up, ask them how their journey went, and ask why they use transport if they were able to manage and make their own way home. And so then we then find out why that happened and then are able to make notes within that system. So if that patient calls again, we've got that information in there and looking at alternatives where needed. Because, you know, again, sometimes patients would go in with a piece of equipment or whatever, and they could have, you know, after treatment, as you probably are aware, and should have used an alternative provision for that. So really trying to monitor and work through that. It's difficult because sometimes, again, it's relative on how people answer questions and things like that as well. Where we've not just turned up, that's again where we're over capacity. We've got so many patients, and you know, it's evolved over time. I mean, I started my career 25 years ago on PTS, actually doing the role, and so it's just changed and evolved even over the last 5 years within the team, and that's that work that we've been doing with Tim, isn't it, in terms of the profile. You know, things are moving out into community settings now. We've got the clinical diagnostic centres, community diagnostic centres. We've got, you know, all services changing, but we have to try and adapt to that in a very relatively short period of time. So there's lots of things that change that we kind of are working with Tim's and stakeholders on. Staff, we're doing great in terms of staff numbers. We've gone through a real positive recruitment process, and we're actually at full establishment. So we've had queues of people wanting to join us, which I take as a positive in terms of when you talk about the issues and how bad it's been or feels, it's busy. It really is busy. It's chaotic at times. I think from a communication perspective, even from when we started the contract, I think from a relationship perspective, PTS has really evolved, hasn't it, in terms of where we're seen within the system, and people are starting to listen and to understand how the service operates now, and I think that's really important. So we don't always get it right, and we don't rest on our laurels in terms of complaints, because we're also conscious that if somebody only has 1 or 2 journeys, they may never complain either. So there's also that you know, out there as well. We've just got to make sure we're not missing some vital pieces of information as well. But it's busy. There's lots of work to do. You know, I'd love to see a sea of green on performance, which would be absolutely perfect. But I think if we can deliver the best service that we possibly can for our patients, I think for me that's what's really, really important, and that's the work that we're trying to do.
If I can just add to that, I think one of your questions was, has it improved? We set out probably 3 issues that we wanted to resolve when we moved from the previous provider. We wanted to get a strategic partnership in place with whoever our provider was, and at the time we set out the procurement requirements. We didn't know that EMAS would get the contract, but the whole point in having a longer term contract is that the provider can work with us on that strategic approach. They can be adaptable. One of those strategic approaches that we've got an opportunity to do now is to start to look at the 999 service and the lower level 999 requirements, and think about whether we can use patient transport to do some of those journeys. It also works in reverse, so when a 999 crew is outside a hospital and they have, they're not being called out to another job, they can perhaps help with some of the discharges from that hospital, and that happens, and it's increasingly happening. So that integration between PTS and 999 is really key. So that was one of the objectives, that was strategic. The second thing we wanted to do, and I said it as we were presenting the report, is focus on what really matters to patients, and I think that has improved from where we were with the previous 2 providers. I can't comment on the previous prior to that because I wasn't around, but certainly for the previous 2. And then the third thing is, does it, for both commissioners and the hospital services and the community services and the renal service, seem to be a better service? And I think my impression, my clear impression, is it does. So the number of issues that I'm getting raised with me as the commissioner for the service are far less than they were for the previous 2 providers. So that long-term approach that partnership approach, I think, is paying dividends. But I'm probably the wrong person to ask. But we've heard, haven't we, that patients seem to be okay with the service, and I think a lot of patients weren't. A lot of patients weren't okay with the previous service. So,
thank you, Councillor Welbury, please.
Thank you, Chair. Well, my first question's actually been answered. Thank you very much. It was who actually books the transport and who actually cancels it. So that's been fully answered. Thank you. Quite a lot has been spoken about complaints and levels of service and safety. I just wondered, do you have cameras on board the vehicles? And, you know, is that reviewed? How's that managed?
Yeah, we do have cameras on board, so that's both for external and internal as well. So we don't routinely review that unless there's a specific incident, so that just wouldn't be viewed unless there's a legitimate cause or reason for that. We have a security team and process in place and governance around that from a patient perspective as well. And so we have internally around our staff safety and patient safety, and so whatever the reason and cause is for looking at the footage would be based on the scenario, and it has a robust governance process then in terms of how we manage that incident as well. And so our staff have access to reporting, and also the patient coming in from a complaint perspective, or also a healthcare professional as well. Yes, 100%, and we don't review the footage if there's obviously that legitimate reason to do so from a privacy perspective. Yeah. Thank you.
Okay, Councillor Kendrick, thank you.
I'll be brief, Chairman. I'd like to concur with the remarks made earlier about delays in discharge due to pharmacy delays. I assume it's a capacity issue, but recently, with a member of my family, had to wait several hours after having been discharged because they were waiting for the meds. But the other thing is really a comment. I think it's pleasing discussing this now. I recall when we had the previous provider of non-emergency patient transport, every meeting we had was depressing because they gave such a poor performance. So I think that, and it's easy to criticise, but I think also we should give praise where praise is due. And I'd like to compliment the representatives today on their report and on the service that they're delivering. I can understand the problems that you have at times, but it's certainly a world of difference to how it used to be in these meetings some years ago. Thank you, Chairman.
Thank you. I don't have any other speakers. I have a couple of questions of my own, really, if I can beg your indulgence. I want to make sure that I've understood correctly a few points of detail, first of all. There's no, or I didn't see any reference in the report to late arrivals. So people arriving at an appointment late, or so late that the appointment is cancelled. So presumably that happens, but I didn't see anything about it in the report. So I'm interested to see, to know what happens with that. And also the definition of a rebed. Presumably a rebed is only a cancellation, is only if a booking to take someone home is cancelled. If no booking is available, that wouldn't count as a rebed. It would simply be a delayed discharge. Am I right? So we actually don't know how many discharges are being delayed because there's no booking available that day. They've got to wait till the following morning. And obviously that's an issue, isn't it? Because we are very concerned about timely discharge, as we've heard earlier in this session. So I'd be interested to know if you have any measures of that, because obviously it is a concern. That's my points of detail. On a larger point, and I don't expect you to go into a lot of detail about it now, because it's going to be covered in another item later on, which I hope you will participate in as EMAS, which is emergency planning, and how the NHS would deal with a civil emergency. And I'm particularly interested because obviously you have a great fleet of vehicles. And what I've never been told in all of the emergency planning work that I've done as a councillor is how your fleet of vehicles would fit in at short notice if a village somewhere between Spalding and Boston were flooded and all of a sudden 2 care homes and a set of sheltered housing had to be evacuated at any time during the day. It could be middle of the night, could be middle of the day. And if you have the resilience to deal with that without it impacting upon your normal day job, if you like. Now, I'd say, I hope that that will come out in the session we're going to have in a month or two's time, but I just wanted to sort of make the point now so you're aware of it. Thank you.
Shall I deal with the emergency response one, and then if you deal with the other two? So part of my role, I participate in the on-call rotas within the county. I'm strategic on-call today, and I can assure you that if there was a need, I would be on the phone to EMAS PTS to say, please can you help as part of that response? Now that response has a rigour and a governance behind it, which is coordinated. So it would be a request out to EMAS. So the point you make about a couple of villages being flooded, we would use all the available resource that we possibly could to make sure those patients are dealt with safely and appropriately. That would be coordinated through possibly a team within the ICB coordination centre. It could be dealt with by a setup of a response through the county emergency centre. So we would use all the resource. One of the really positive things about the relationship with EMAS is that we can take that integration as well. So whether it's 999, you can kind of box and cox a little bit between 999 and PTS, but we've got that resource in one place now, and it's far easier to call on it, in my view, although the contracts with independent sector providers will always say they've got to be part of the emergency response. It's far easier to deal with an organisation that is well versed in an emergency response when you have that issue to try and resolve, and that integration is really important.
Yeah, absolutely. So on the other points as well, in terms of arriving late and then not having their appointment or treatment, absolutely, that can happen. What we do a lot, and again it relates to kind of those telephone lines being kind of taken up and the availability on that, is contacting and liaising with clinics when we know a patient's late, they're going to be late in. Can you still see that patient? Because what we don't want to do is be in that situation if we can avoid that. So there'll be options that, yes, we can see the patient, but they need to be here by this time. Or no, we're not able to see the patient today. However, we can book in and see the patient either another day or, you know, and so we have that kind of three-way conversation then with patient and clinic and our own teams in being able to manage that. But that does occur as part of those late journeys, which you rightly point out. And from a rebed perspective, so yeah, absolutely, if there's varying levels. We do monitor where the patient is delayed and it goes into the next morning as well. And so we send a report through our quality papers, and that breaks down by individual journey, the reason for a delay that's gone overnight, and then how many hours then that patient's been taken to get home. But also there are patients as well. So some patients where, you know, if they're booked in really late at night, it really isn't suitable for the patient to travel, and so there's some elements around the appropriateness. But there's also some patients that want to travel regardless what time, they just want to go home, and so we have those journeys as well, irrespective of whether we're in a service delivery principle or not, that will travel throughout the night. And also we continue, we have the 24/7 service anyway, because we operate from the accident emergency department as well, so we try and keep that patient flow going as well, where you know, patient hasn't been admitted but needs to travel home overnight as well. So but that's all, we document everything, and it's all recorded and reported, and we do a validation process on those rebeds as well as to root cause.
Thank you for that. There being no other questioners, it leaves me to thank you for coming out. Thank you for the report. Thank you for being so patient with us. And we need to come to a proposal. And the proposal is that the presenters be thanked for presenting information on the non-emergency patient transport and for answering the committee's questions. That the committee notes the responses to those questions, and that a further update be requested in a period of 6 months. Do I have a proposer, please? Councillor Kendrick, thank you. A seconder, Councillor Scalesi, thank you. All those in favour, please show. Thank you. All those against? Any against? Any abstentions? No, that's unanimous again. Thank you very much indeed, and thank you again. So finally, members of the committee, we move on to item 7 of the agenda, which is the work programme. Simon Evans, Health Scrutiny Officer, to introduce the work programme, which you can find on pages 113 to 117. Simon.
Thank you, Chairman. I've no additions to the work programme as is listed on pages 114 to 116 as currently listed, so no confirmed changes. If you could just indulge me today, I would like to introduce, well, Chiara. Chiara is well known. I'm retiring at the end of this month, next week actually, 30th of January, and from the beginning of February, Chiara will be undertaking the role of Health Scrutiny Officer. So I just want to report that. I will circulate Chiara's details. I know county councils will be familiar. Chiara has been in the scrutiny team here for about 4 or 5 years, and so county councils will be familiar with the details, but certainly I'll circulate details to all the district councillors. Thank you, Chairman.
Thank you, Simon. Sorry, I just lost my spot there. Okay, so we note the confirmed items of business for the forthcoming meetings of the meeting as set out in section 1 of the report. So we take that as noted. Anybody happy? Anyone to add? Sorry.
Well, yeah, sorry. I don't really like to ask this, but because I might be tempting fate. But the urgent treatment centres, we haven't had an update about those, and there was I don't know whether to ask for one or not.
Yeah, certainly. Actually, I was thinking the very same thing when I was looking through the papers this morning for the meeting, and thought, yes, that's one of the things that we need to cover off because it is always a concern. Urgent treatment generally. Yeah. So I'm happy to add that to the list of things to be scheduled if the committee agrees. I'm seeing lots of people nodding. That's lovely. Okay, that's fine. Anything else? Anyone would like to add? Okay, we'll take that as read then. So that closes that finishes the business of the meeting. Simon has stolen my thunder because I was going to point out that this is his last meeting, and obviously, as you'll be aware, he's been serving this committee for a long time with great diligence, ever since I've been a member of it anyway. So I would like you to join me in offering him our thanks and best wishes for his retirement. Thank you all for attending, and that concludes the business of this meeting, and our meeting is now closed. Thank you very much.